everyone, and welcome to our third day. Sorry, we will begin shortly. Please wait for a while.
Good morning! Welcome to PEFRI's 17th Annual Postgraduate Course entitled Code White. This event was organized by the following individuals: Dr. Julius Dalupa, Dr. Tim S. Trinidad, Dr. Jude Giang, and Dr. Maria Cristina Marañon. We hope that you'll enjoy the 4-day webinar series we've prepared for you and get a chance to win exciting prizes on the last day. Let's start learning. Let's enjoy and start the program. Let us now call on the virtual floor our moderators for this morning, Drs. Marañon and Uy.
Hi, good morning once again, everyone, and welcome once again to our third day.
We hope that you are ready to tune in for the next 4 hours to our esteemed speakers.
Our first speaker graduated and trained at UST and had his Masteral of Medical Law and Ethics at the University of Edinburgh. He is a member of the National Ethics Committee of the Philippine Council on Health and Research and Development of DOST and the current chair of the Department of Medical Ethics of the Faculty of Medicine and Surgery at UST.
He is not only ethical but also outstanding and multifaceted, as he is the current training officer of the Pulmonology Fellowship Training Program of UST and the chair of the Council of Diagnostics and Therapeutics of our society. May I call on the virtual floor the indefatigable Dr. Roland Panaligan.
Thank you very much, Dr. Uy and Dr. Marañon. So I hope you can see me and hear me loud and clear.
Yes, Doctor, we can hear you. And
okay. I'll start sharing my slide. Okay, so please let me know if you can see my screen, my slide.
Copy, sir. We can see it.
Okay, thank you very much, Dr. Marañon. Good morning, everyone, and welcome to this third day of the PEFRI's 17th postgraduate course. And for this morning, I will be talking about an equally important topic. These past few weeks, we've been talking about certain respiratory diseases and diagnostics, but this time, an equally important topic as we will talk about palliative care, especially now in the current community quarantine or in the current pandemic. Now, in the next few minutes, I will be talking about palliative care, especially among bedridden patients, especially now that we are in community quarantine, or some of the areas in the Philippines were in community quarantine. And we will go to the second part as we talk about palliative care again for patients admitted in some institutions. And the majority of my presentation will be based from the statement or from the guidance which was presented by the Philippine Society of Public Health Physicians last June 2020. Okay, so let's start. When we speak of palliative care, basically it is an approach to care that improves and emphasizes quality of life. But sometimes there is a misunderstanding that when we speak of palliative care, we always talk about those who are dying already, those who are terminally ill, stage 4 malignancy, for example. That may be correct, but in general, when we speak of palliative care, it may be simple. It may be as simple as controlling or alleviating some pain or discomfort. May masakit sa'yo, tinanggal yung sakit or discomfort, that is a form of palliation already. So someone need not be dying to receive palliation or palliative care. And another important angle when we speak of palliative care is that this particular approach will not be particular or focused among patients only, but to their families as well. So that's very important to look into. So we look into the patient and the families facing problems associated with life-threatening illnesses. Commonly nga lang, the application will be there, but in general, it can be applied to any particular disease entity. So, and the approach not only involves treating of symptoms, because we start with prevention. We understand what is the cause of that particular symptom. We try to predict what symptoms would likely occur in certain illnesses. So our effort will be towards that, controlling the symptom. And of course, we understood bakit ba siya present or absent in case. After the prevention comes the relief of the symptoms based on the underlying illness, and then we provide rehabilitative support. So that's the very essence when we speak of palliative care, and this is from WHO. Now, very important to look into would be the physical manifestations of probably some discomfort that we encounter when we speak of palliative care. So these are the common health concerns for primary palliative care. So we focus our intention to the physical. Okay, so it may be pain, it may be respiratory problems, and common example would be shortness of breath or coughing, or at times there would be gastrointestinal problems. So some patients or individuals may be constipated already, may be experiencing some form of nausea and vomiting, or because of dryness, mga oral sores or mucositis, and even diarrhea. Now, there would be delirium, or for chronically bedridden patients, there would be presence of wounds or ulceration. Some of them may have insomnia or fatigue. Another thing would be anorexia, anemia, or sometimes drowsiness or sedation if they're receiving some medications, and the physical sweating. But apart from physical manifestations, we likewise look into emotional, psychological, or sometimes even spiritual form of distress that patients may be encountering. So that may include psychological distress or anxiety, some form of suffering. And mind you, suffering will not be limited to patients. It may be extended to their family members and even to their carers. So spiritual needs will be very important because di ba, what will be your true essence? What will be your quality of life? Okay? So some spiritual considerations during end of life will also be important. Some of the patients may be depressed because of the general medical condition, or sometimes because of lack of social support. Okay, bereavement support will be very important for the family and carers as well. So physical, psychological, mental, those are the aspects that we need to look into when we speak of palliative care, no, kahit nasa bahay lang siya. So let's talk about care in the home. The very essence of care in the home is about empowering the family members. So how we teach them how to take care of the patient. And it's all about the assurance of their capacity to take care of the patient. You need not be a healthcare worker. You need not be a doctor, a nurse, etc. All you need to do, or all you need to have at the minimum, would be the basic care and compassion for your individual patient. So this time, more or less, or hopefully in an ideal setting, we make sure that about 2 or 3 family members or carers will be familiar with palliative care principles. And this is important because during this phase of social distancing or physical distancing, we have this pandemic. We try to limit the care of the patient only to these identified family members or carers or caregivers. This is important because we try to limit the possibility of transmission in case there would be infectious process that will be involved. Not necessarily COVID. It may be ordinary flu-like illness. Okay? Ayaw natin na matransmit from one patient to another. And very important to highlight, look at the last bullet, the carer should regularly wash their hands. We do not share personal items with the patient. And very important, we clean high-touch surfaces. Diba? The doorknob in the room or baka switch buttons, your gadgets, if ever, na ginagamit siya. So, some tables. So, all of those are high-touch surfaces. So, usual or regular disinfection and sanitation will be very important. And last, monitor one's symptoms. That's very important, especially now that testing will be guided. No, if one individual will be experiencing symptoms, so very important is to monitor the symptom. What about COVID-19 patients, no, who may not be admitted or isolated in a quarantine facility? We ensure that if that patient is coughing, it will be covered, and that the caretakers have or the caregiver have personal protective equipment, and we are familiar with steps to prevent the spread of infection in that particular area. And this will be for worst case scenario wherein patients with low survival rates will be advised for home palliative care. Okay, of course, this should be in a in a collaboration or coordination with the local SESU or barangay health unit. No, kung minsan may mga ganong instances, di ba? Because of futility or personal preference, etc. It may be a case that some COVID-19 patients will be taken at home. So we monitor patient symptoms and watch out for new onset of fever, coughing, and other flu-like symptoms. Kasi baka basically nung una wala, mild or very asymptomatic, then later patients may be developing symptoms. So that has to be monitored and to be reported. Okay. So apart from monitoring the patient per se, the fourth bullet mentions monitor for carers signs of burnout. Okay, napapagod din. May mga physical and psychosocial needs din si caregiver, si carer, si family member. So it's very important to identify that so we can provide psychosocial support. Diba? Ano yung bumabagabag sa kanya? Napapagod na ba siya? Okay, is there something bothering that person psychologically and emotionally? So care and comfort should be given as well. Then we prepare a contact list for essential referrals and support. It may be the hospital, the social welfare services, possibility of emergency transport in case, and even spiritual needs will be very important. It's not always the physical aspect or the medical aspect. We look into the spiritual and the spiritual needs of the particular patient. Now, when we look into common symptoms being encountered at home, that may include pain management, no? Very important is to determine the cause of the pain. So we ask the history, we try to do some physical examination, then we try to identify the pain could be of two types. Is it a background pain that the patient usually experience most of the time? Lingering, nandun na siya, persistent. Or this is a breakthrough pain, which is defined pain which could be incidental. It was only triggered by movement or or could be spontaneous, also known as pain in exacerbation. Okay, so we differentiate that two types of pain, background or breakthrough, then assess if the patient is suffering from which one. Then we provide care, we provide comfort through pharmacologic methods if available. Then in the end, we assess if there is a psychological or spiritual component. Minsan ganun eh. Okay. Now, very important in the assessment of pain when we speak of palliative care at home would be this one. No? Diba? This is like the yung visual analog scale. Okay? So, pain scoring, pain severity, tatanungin, 10 being the worst, is it more or less mild, about 0 to 3, or is it moderate, 4 to 7, or it is a severe form of pain, debilitating the patient, affecting the daily function of the patient. So, that will be important. Okay? Then we try to apply this WHO analgesic ladder. So if it is a mild form of pain, then probably we can opt for this one, a non-opioid preparation. So aspirin, if there is no direct contraindication, or the usual analgesics that we use, like paracetamol or your NSAID, again, if there is no glaring contraindication. So excuse me. So ideally, when you give your pain medications, especially in chronic pain, it should be in a timed fashion or manner. If it is every 8 hours, it should be every 8 hours because we want to maximize the comfort of our individual patients. Okay? Then, what if nagbigay na tayo ng paracetamol or NSAID and ganun pa rin, the pain is still persisting or increasing? And another tip in pain management, di ba? We try to advise our patients na hindi kailangan mag 10/10 before we give an intervention or a medication. As long as the discomfort or pain is there, we try to address that already because we want to maximize comfort. Okay. Hindi umokay sa aspirin or paracetamol, for example, then we can try other options as mentioned in step 2. Okay. So we can have, for mild, more to moderate pain, you can have your weak opioids, and an example would be your tramadol. But again, when we give intervention, hopefully we maximize the benefit or the effect. Kaya lang kasi baka pag binigay, especially for mga tramadol, yung iba, they become nauseated or they are vomiting. And we added another symptom and we do not like that. And of course, at the end of the line, pag talagang masakit na masakit, breakthrough pain, background pain, masakit na masakit, 10/10, then we try to consider strong opioid to moderate severe pain, and a good example would be morphine. But of course, it is a controlled substance, and of course, we should also be mindful of its potential side effects. Now, other additional methods for pain control would be as follows. Pwede din namang non-pharmacologic. We are in palliative care, di ba? So, warm compress, warm sponge bath, or breathing exercises, okay, they may help in alleviating the pain of a particular patient. Very important also is to provide encouragement and emotional support, and we communicate with them, di ba? And distraction may also help. Baka may family time, watch favorite movies or TV series, and other form of distraction may likewise help in addressing or alleviating pain. Okay? So what else? So that's for pain, but in general, when we look into general symptom management approach, di ba? Parang mag-history taking din tayo no? So what precipitated the pain? What is the radiation? What is the character or quality? Is it associated with other manifestations? Yan. But importantly, we determine and treat the underlying cause of the symptom. Yes, we may give symptomatic remedy, but a more definitive approach is to try to address the etiology. Then identify, is this something physical or non-physical? Usually kasi kung physical, may baka gamot. Non-physical, it is psychological or emotional, the intervention will be different. And very important, treat symptoms without causing new symptoms. Di ba katulad na nabanggit natin kanina, may pain, nagbigay ng tramadol, pero after nahilo, nasuka. Di ba? So the patient should be better off after our intervention. Hindi, they will be worse off after. So we consider pharmacologic and non-pharmacologic measures, but at the forefront should be the best interest of our individual patient. Ano ba yung tingin natin na makakabuti sa kanya? Di ba? Our mindset should be very objective. Now, let's look into common symptoms that may be encountered for palliative care at home. It may be respiratory symptom, and that would include shortness of breath. So we advise the patient kung kaya to keep the head up, try to lean forward, and or consider breathing exercises, di ba? Hinga ng malalim, breathe in, breathe out. Kung may window, di ba? Para may mga mas sariwang hangin sana na makapasok, especially if they're not living in the polluted NCR. Or probably we can cool the face by using a cool cloth that can likewise help. So, give the patient water frequently. Hindi naman lunurin, baka mag-congest, no? So more or less just to give comfort. And if the patient is anxious, in distress, no, yung parang kinakabahan, nervyos, again, assurance will be very important. We try to identify situational components. Baka naman nag-alala, nagalit, natakot, nag-aalinlangan. So we try to identify that so that will be addressed. And we teach behavioral intervention. Sabi nga natin, relaxation or any form of lifestyle modification will likewise help. What about coughing? Diba? So we encourage them to sit up and proper positioning. Baka kasi nasasamid or nag-aspirate sa laway nila. We try to humidify the air with steam. Hindi ibig sabihin steam inhalation. Kasi minsan when the air is very cold and dry, it irritates the upper airway. So, di ba, kung merong humidifier, that may be possible. Or basically controlling the temperature inside the room. It should not be too hot and it should not be too cold. Physiotherapy. dati na natin ginagawa to assist secretion drainage, and cough suppressants may be given. No? May mga available naman in tablets or in syrup which can be given. And very important is to look into other possible sources of irritation. Baka may naninigarilyo, baka may nagsisiga, nagsusunog ng plastic or goma. Not necessarily inside the house, no? But, di ba, the perimeter or di ba, na adjacent to the house, and that may be a source of irritant. Gastrointestinal symptoms would include nausea and vomiting. So, para hindi lalong mag-aggravate or exacerbate, we try to offer small, frequent feeding. Pwede din to take drinks slowly or using a straw, that can help. And if vomiting and the patient will be unable to sit up, di ba? Turn them to the side. And in that way, we can likewise prevent the possibility of aspiration, hopefully. Included also in gastrointestinal symptom would be constipation, no? Hindi makadumi, which is defined as less frequency of stool per week or per day, or difficulty of bowel movement in more than 25% of the time. So we try to identify bakit ba constipated. In general, they may be inactive, hindi gumagalaw, so peristalsis will be affected. Or probably they have dehydrated, o wala namang kinain, edi wala talaga siyang ididumi. But other causes may include fear of opening the bowels. Paano kung may mga fissure o may sugat na yung perianal area? So baka minsan natotrauma sila. Or if they need assistance, the carer is not helping them regularly. Or pag mas malala, baka there may be form of bowel obstruction, and this is an urgent concern. Or neurological dysfunction or drug-related po pwede rin cause ng constipation. So what are the actions that we need to consider? Often drinks often, usually yung mga high fiber drink like the prune juice. We can offer, di ba, light abdominal massage to increase peristalsis in that area. Change position if kaya. We can apply warm bag, especially on the abdominal area. Pero yung hindi talaga, baka rectal stimulation may help, but hindi lang plain rectal stimulation. We try to apply petroleum jelly, no? So more or less to act as a lubricant. And manual evacuation will also be a consideration for those who are trained to do that. What about psychological or emotional symptoms, especially for our bedridden patients? They may present as confused with the signs of delirium, or they are restless. So let us assess, ano ba yung cause? Is it something reversible or irreversible? Baka naman may gamot na ibigay. Or is it something metabolic? Mababa yung potassium, yung sodium? Or is this form of sepsis syndrome? Baka naman may infection. Okay? Or may new onset neurological deficit. This will be important and need to be communicated to the family. Okay? Especially if it is reversible or not. Then what are our specific actions? We keep, in general, no, keep the patient in a familiar environment so hindi sila nai-stress. Di ba nga sa hospital, merong mga ICU-induced psychosis, di ba? Okay? We try to remove dangerous objects. Baka kasi makasakit sila o masaktan nila yung sarili nila. We always talk to the patient and reassure them, and explore for uncontrolled or hidden pain. Baka naman doon nang gagaling. Hindi natin nakita, laki na pala ng bed sore. O kaya pala nagdi-delirium na or very restless, no? Sobrang distended na pala yung bladder. It may be functional or it may be secondary to medications that are being given. Okay. Now, what are preventive strategies naman, no? So in general care, for preventive oral care, we use a soft toothbrush to gently brush the teeth with toothpaste. Kasi mamaya, di ba, tinoothbrushan, lalo na kung another person is doing that, nasusugatan or nagbi-bleed na yung gums. Gargle with gargle solution, chlorhexidine but not as common. What we have would be 1% povidone iodine. Meron tayo niyan. Actually, wala nga yun sa US or sa UK, but very common in Southeast Asian region, yung 1% povidone iodine gargle solution. So it may function as a general antiseptic in the oral cavity. But if it is not available, ito, meron tayo lahat. An alternative would be salt water solution. And how do you prepare that? 1/4 to 1/2 table salt, no? Na teaspoon combined with your 8 ounces of warm water will be a very good alternative for oral hygiene. Now, for patients who cannot gargle, ginagawa natin to sa hospital. We dip a soft cloth or clean gauze into the solution. Then we brush that to the teeth, tongue, and inner cheeks. And that should also be an opportunity para ma-check, no, yung ngalangala, yung gilagid, baka nagsusugat, o baka may mga oral ulcers na. So that's part of preventive oral care. Another one would be preventing bed sores. Now, let us try to understand the different contributing factors for bed sores, and it should be addressed. One, pressure, kaya nga pressure sore or pressure ulcer. So commonly pressure on bony prominences. So we need to identify that, and we need to be on the look for that. Friction, ng kikis-kisan, no? Yung mga bed sheets, especially if the bed sheets are very dry, no, o hindi cotton, maaligasgas yan. Or shear forces usually happens when trying to grab the patient to a sitting position. So the carer should be very careful. Diba minsan nagkakapasa-pasa o nagkaka-dislocation baka sa pag-handle. So these are the three contributors. So we need to pay particular attention to pressure, friction, or shear forces. And other preventive strategies would include, ginagawa din natin to, especially in hospital setting, di ba? Um, comprehensive or regular bed training, usually 1 to 2 hours, or sometimes you use pillows in between bony prominences, another effective approach. And we keep the skin, clothes, and bedding clean and dry. Kasi kung moist and damp, usually it promotes formation of your bed sores. Passive range of motion as a form of exercise will be there to decrease again the risk of having bed sores. We mentioned to keep the bedding clean and dry. And di ba, pag tinitignan, we look for skin changes already. Baka hindi napapansin, may namumula na, may nangingitim na. So that may be an early sign already. So we need to be on the watch for that particular area. And another usual remedy that can be given yung mga zinc oxide and calamine on sites of redness to avoid progression because this will act as a barrier on that particular area. What about paliligo, no? We need to provide privacy. Hindi porket bedridden, matanda, no? Hindi na natin i-offer yung privacy. So dapat, 'di ba, yung pagpapaligo, that particular process should be with privacy. And for patients who could still go to the bathroom, so sana nasa monoblock sila. Hindi mahirap yung nasa toilet bowl eh. Maganda yung monoblock kasi 'di ba the back could be supported by the chair itself. And do not rush the bathing process and should be thorough so that the carer should also do a complete physical examination. Nakahubad yung patient eh. So makikita natin the joints, the skin, yung likod, di ba? The perianal area, the groin. So that's the best opportunity to look into possible mga signs of infection, okay, o mga break in the skin, etc. You use warm water to avoid to provide more comfort. And for patients who are quite anxious or uneasy, pwede tayong may soothing music at the background or parang may aroma oil ka pa that could be burned no dun sa area. So dapat hindi irritating, okay? Parang may spa-like environment. So for patients with pre-existing painful conditions, yung may mga arthritis, okay, o kaya yung mga contracture, pain medications may be given few minutes prior to bathing, no? Pwede na tayo magbigay ng paracetamol, for example. Then after we dry the skin with a soft towel, no, para hindi tayo maka-inflict ng wound or abrasion, then minsan no, yung mga non-scented lotion. Kasi di ba minsan their skin is very dry, wala na masyadong hormones. So a non-scented cream or lotion may help as well. We use plastic sheets under the bed sheets to keep the bed dry when doing a tepid sponge bath. Diba? Para, or bed bath, so when the patients cannot control their urine or defecation, hindi masusok yung particular area. Then again, zinc oxide and calamine lotion could be applied on the anal orifice as an antiseptic or to prevent anal fissures or sores. What about pain and stiffness? As we mentioned, minsan, di ba, dahil bed-bound, bedridden, matagal na, nagdikit-dikit na, nanigas na. In general, sana we can encourage them to move, to mobilize. Okay, but if the patient is immobile, passive range of motion, upper and lower extremities will be helpful. And for patients with pre-existing painful conditions like contractures, bone pain, talagang magbibigay tayo ng gamot no, prior to any form of exercise or movement. Light pressure or massage may also be effective to some patients, but not to the point ng, di ba, na talagang ginalaw, ma-dislocate. No? We need to be very careful. Now, we mentioned several strategies already, no? Cough, gastrointestinal, respiratory, okay, preventive oral, bed sore, paliligo. But what will be the indication of referring particular patients at home home to higher health facility or provider. So basically two things. If there will be a failure of the initial control of moderate to severe symptoms that may be related to serious or complex or life-limiting health problems. And the second one would be failure to control refractory suffering. Kasi we are after palliation eh. But if we are not meeting our very objective of providing comfort, then that should be a red flag to us. Hindi na natin kaya sa bahay, then higher health facility or provider should be called in. What about end of life? No, nasa bahay. So patients in terminal phase but non-COVID. Di naman lahat ngayon COVID eh. So non-COVID, ganun pa din. Maintain standard infection control procedures. We need to give reassurance to the family, providing support and communication. We do active listening, counseling. So again, it's a form of reassurance. Encourage communication within the family. What will be done after kung sakasakali ngang namatay na? Kasi di ba nasa terminal phase. Di ba? Hindi naman yun about morbidity, but it is about being open. Di ba? Advanced planning. We monitor and address symptoms with nursing care medications and we cease non-essential medications. Kasi kung hindi na kailangan, bakit pa? Di ba? Especially at the end of life. What about COVID-19 patients at home? If any, care must be given, of course, to the safety of the patients. Visitors, not likely, usually family members yan. If patient is assessed to be in irreversible phase of illness, we inform everyone already. And the one taking good care of the patient should be in proper PPE. Kung kailangan talaga ng psychosocial and spiritual support from another third party or another person, it can be done via telecare or video calls if the provision is there. And if death is imminent at may gustong family member that wants to be at the bedside, proper PPE pa rin should be there. And we encourage the family to maintain brief yet meaningful communication with the patient. After all, that may be the last time. Always, 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 dapat may proper PPE even at the post-mortem. We respect the body. Yung body bag should be used in transferring the body kasi di ba simple movements, baka may mga droplets pa dyan. And the disease properties such as clothes and blankets should be disposed of. Then yung iba naman, it can like jewelries may be disinfected. And the body should be cremated within 24 hours. What about the family? It doesn't end there. Bereavement. We look and respond to grief reactions. Some of them may be in denial, disbelief, confused, shock, hindi pa matanggap. That's part of the process. But we try to help them, no? Accept the death of the loved one and pag-usapan and talk about positive things when the patient was still alive. And again, for the family, try to see if friends can offer practical help inside the house kasi minsan hindi na sila makapag-isip. Monetary problems, very common, especially in our setting. Diba? Baka government agencies, DSWD, politicians who may help or encourage them to have patience and that the grieving process could take a while. But in the end, kung kailangan talaga ng support, community bereavement kung meron if available. Now, on the second part, optimizing naman hospitals for provision of palliative care during the pandemic. So, hindi agad-agad. Dapat meron tayong stockpile of medications. We need to have a trained staff. We need to have a place no, or an area. Hindi pwedeng halo-halo. Okay? And a system for that, triaging, etc. So basically, it's a shared responsibility. The administration, healthcare workers, the patients, and their family. And very important in that context would be advanced care planning. Sa hospital setting kasi, ang paniniwala natin, nandito yung mas may potential na lumala. Nandito yung mga more aggressive. But it is very important in the context of advanced care planning to ensure timely, open, honest conversation. What will be our preferences or what will be the patient's preferences and priorities prior siya ma-admit, prior siya lumala o magkasakit? Okay? Because we need to identify a certain ceiling of care. What will be the prognosis? Okay? There may be emergency or urgent situations wherein health professionals may have to triage patients and prioritize particular interventions. Okay? This is not only to ensure that those with significant potential to recover receive appropriate care, but also that those who are unlikely to survive will receive appropriate care, especially in the context of end-of-life care. So as the physician, we explain the likelihood of the disease becoming more severe. What are the options? But very important, ano kaya yung personal decision ng patient if it is available? And hopefully, it is available. And in the process, we involve the family. Kasi sometimes they are the surrogate decision maker eh. Paano kung comatose na or in delirium na yung patient? We cannot rely on the patient and ask the patient for some considerations or decision. So consider that families and close relations may be overwhelmed. So we try to provide assistance and consider that the patient's carer, members of the family, may themselves be ill. Yan yung nangyayari ngayon eh. Okay? May sakit pero walang makapagbantay. Bakit? I-quarantine din sila or some of them may be even be symptomatic. O kaya yun yung mahirap. It creates a complex scenario but we are here to help of course. And we consider the use of technology, telephone, Zoom meeting, other social, not social media, online platforms that may serve as a bridge for communication. So, pwede natin gamitin yung spikes, no? This was published in the Oncologist in 2000, Breaking Bad News Cancer, but in the context of end-of-life care and advanced care planning, pwede rin naman siyang gamitin. We set the situation, di ba? Dapat alam natin yung background. Perception, ano na bang alam ng patient or ng family member? So, we know where to start, we know where to end. And then we invite, how much do they want to know? Balancing what they need to know or what they do not need to know is quite challenging and difficult. But we need to try our very best. The knowledge, sasabihin na natin, what is the assessment? What will be the plan? What will be the alternatives? But when doing so, it should be made in a very simple language, easily understood by them. We show empathy. Busy tayo, laging nagmamadali. But we need to be sincere. We need to be empathic. Then in the end, summarize. What will be the strategy? What will be the options? So that you will agree. So that's one step. Now, other common symptoms in the hospital, it may be dyspnea. We talked about this already in terms of positioning or pursed breathing, yung mga cooling techniques. We just try to avoid yung fans. Before kasi, di ba, sinasabi natin yun, no? To pacify yung mga nerve endings, pwedeng fan. But paano nga ngayon in the context of a pandemic that may be quote-unquote aerosolizing procedure, baka lang. So baka pwede na lang cooling the face by a cool cloth. And in the hospital, we use morphine or sometimes fentanyl. We refer them usually, di ba, sa palliative care medicine. Or for those na meron ding anxiety, midazolam is another option. But we look into possibility of constipation, di ba? Sabi nga natin, after the intervention, the patient should not be worse off. Mamaya, they are suffering from other adverse events because of the medication. So, we try to balance that. For severe respiratory distress, nagdi-drip na. Again, being given by a qualified specialist, it can be morphine drip, or for patients with AKR or CKD, fentanyl naman would be another option. Basic, umuubo, they cover the mouth. We dispose of used tissues promptly into clinical waste and hugas parati ng kamay. Paulit-ulit tayo dyan, whether hospital or home setting. Non-pharmacologic measures, the room should not be too hot or too dry or too cold then. Honey and lemon or ginger in warm water can provide some comfort and elevate the head, and avoid any other triggers like smoking. We mentioned earlier minsan, no, mga antitussive, so butamirate citrate and levodopa-propycine, available naman yan. Or for some, pwede rin naman morphine sulfate. But if all of these measures will fail inside the hospital, then we can easily refer. Pwedeng pulmonologists, palliative care specialists, some of them, it may be anesthesiologists. So other options may be given, steroids, bronchodilators, and even morphine. What we would like to emphasize would be working with a multidisciplinary team, di ba? Para may interprofessional collaboration and coordination. And these professionals will talk among themselves in planning what will be the best care for the patient. Kaya nga merong mga junta medica or medical junta. Then after, when everyone is on the same page, we go to the family. Then we have the family meeting. And of course, I think yung mga institution is really providing for a structural framework in terms of that particular communication. And the aim is to encourage a sense of mutual understanding so that the patient and the family will be satisfied with the amount of care being given to them. What about advanced directives? So ito, nabanggit to, no, especially sa PSMID and one of our mentors in ethics, Dr. Alora. Advanced directives, the free and informed decision not to resuscitate made by a competent patient through advanced directive should be followed. Okay? So that is something valid naman. It is documented, it was done with a competent individual. But without a patient's advanced directive, kanino manggagaling? It should be an appropriate proxy. someone with a special power of attorney, a legally authorized representative or guardian. If you are married, your husband or your wife. Kung wala naman, single ka, it may be your parents or your siblings. So there is a certain hierarchy. Pero kung wala rin yun, the medical team can make the decision based on three parameters. So let us remember, futility. Is it reversible or irreversible? What are the chances? Two, what is the best interest of the patient? I am the clinician. Anong tingin ko sa kanya? And scarcity of resources. In the context of a pandemic, allocation of resources will be another consideration. So the medical team may withhold CPR and look at the following cases: ARDS, high-risk pneumonia, okay, not responding, refractory septic shock, or multi-organ failure. But of course, we need to follow the first bullets that we discussed. But towards the end, efforts must be made to provide spiritual care and counseling for the patient and the family. We should not be sobrang centered sa physical no? So dapat psychosocial, emotional, and spiritual needs should always be considered. Now, so I think that's the end of my slide. But for those of you who would like to review, you can visit the Philippine Society of Public Health Physicians, because this is a local flavor on how to do palliative care, especially in this time of pandemic. And at the end of the day, no, October 10, 2020, di ba, nag-commemorate ng World Hospice and Palliative Care Day, because at the end of the day, we believe that it is not our, no, our comfort, our own anxiety, our own distress. What will be important at the end of the day would be the individual pain, anxiety, and distress of our patients. So all of us should be advocates of, di ba, my care, my comfort. My meaning not us, di ba, the patient. Ano yung pinagdadaanan nila? So we should be an advocate of our patients or those who will be needing palliative care. Palliative care is a part of the integrated people-centered health service. Marami kasing hindi nakakaalam, sabi ni WHO. So we feel that majority needs palliative care and yet they are deprived of it because of lack of awareness. So I hope in the past few minutes that I've been discussing this one, di ba, medyo naging aware tayo on what will be the specific role of palliative care in medicine. With that, thank you very much for your attention.
Thank you, Dr. Panaligan, for that very enlightening talk. Palliative care is usually not emphasized in other medical schools, and it's refreshing to be enlightened about this topic, Doc.
I agree, Giselle. Dr. Panaligan gave a very informative and practical talk. We need to talk about this because we know that Filipino families are tight-knit and very involved in patient care. Doc, I have a question po for you. Have you tried po telemedicine as an avenue to render palliative care? And how often should we check up or follow up on our patients po on palliative care, whether it be through telemedicine or face-to-face po? Such as, for
Okay.
example po, yung home visits, doctor.
Okay. So first, personally kasi hindi ako nagte-telemedicine. No? I'm not a techie person. I'm not used to technology platforms. But if the basic question is, can palliative care be done through that platform? If it is for reassurance, communication, basic appraisal, follow-up, yes, it can be done. Then in terms of frequency, no, it depends on the need. If the patient is relatively stable, that can be done on a weekly basis. Pero kung meron talagang mga urgent concerns or symptoms and the family or the patient would need to communicate to the practitioner, it can be done every so often. There's no hard or fixed rule naman about it. So it can be done daily or every 2 days. But in general, kung wala naman stable, di ba, every week na follow up or pagkamusta, no? It can be likened to a home visit noong meron pa tayong face-to-face interaction.
Okay, thank you, Doc.
Thank you, Doc, for your answer, Doc. There's another question po at the chat box. How do you deal with families, Doc, who interpret palliative care as giving up on their loved ones?
We try to communicate pa rin naman. Di ba? Best strategy is try to explain. It's not about giving up. Sabi nga natin, palliative care. Once we identify the ceiling of treatment, o hanggang dito lang we can stop treating but we cannot stop caring. Pwede naman yun wala kang gamot, wala kang intervention, but the care process is continuous. So that's palliative care is all about. So it's not giving up. hindi ibig sabihin na hindi mo binigyan ng gamot, sumuko ka na. Kasi naunawaan mo na maaring wala ng role ang gamot, diagnostics, or intervention. And that will only be possible after a very good communication with the patient or their family.
Okay, thank you very much, Dr. Panaligan. That was really a very fantastic lecture po, Doctor. And with this, we would like to present the certificate of appreciation to Dr. Panaligan for having lectured in the 17th PEFRI postgraduate course signed by the organizing committee. Thank you, Doctor.
Thank you.
Our second speaker graduated and trained at the University of Santo Tomas. He is the most prominent resource person to talk about TB, having been the past national chair of PhilCat and as the immediate past chair of the Council on Tuberculosis of the Philippine College of Chest Physicians.
He is currently the head of the Adult and Pediatric DOTS Center of the UST Hospital. May I call on the virtual floor the very erudite Dr. Jose Hesron Morfe.
Okay, good morning. Can you hear me?
Yes, Doctor, we can hear you po.
Okay, I'll start sharing my screen. Okay, so our topic this morning is to talk about healthcare associated TB and focusing on surveillance and prevention in the new normal. So I'd like to start my talk by giving you the latest statistics for TB worldwide. The Global Tuberculosis Report 2020 came out, and we noted 10 million individuals still contracted TB in the last year of 2019. Basically the same as 2018, except that the range actually changed from 9 to 11.1, went down to 8.9 to 11. And then in terms of the segregation of cases, from 5.7, we now have 5.6 million men, 3.2 million women, and 1.2 million children. So 88% were, of course, in the adult division, and there were 8.2% people living with HIV. So you all understand that HIV is a significant risk factor for a TB-HIV co-infection. Now, in terms of drug-resistant TB, nearly 500,000 developed rifampicin-resistant TB, of which 78% had resistance as well to rifampicin. In terms of ranking, there were 8 countries that accounted for 2/3 of the world's case burden. The rankings are essentially the same, except for Indonesia and China, which basically exchange places. And then the Philippines is still at number 4. As you can see in the lower part of your screen, we are part of those that are basically dealing with TB and slightly MDR-TB. Okay, our HIV cases are not as many, so it's still 1% of our population, but it is a significant risk factor. We are one of the countries with the increasing number of HIV cases, so this will play an important role in the succeeding years. So TB is still one of the 10 leading causes of morbidity in this country, and it went down from number 6, went down to number 8, and now it's the 10th place. Okay, this would include those with HIV, now estimated at 11,000 cases. Now it might be of note that only 1,600 cases have been actually diagnosed, and of this, slightly less, 1,500 are on antiretroviral treatment. So as a country, our estimate from previous of 592, we're now at 599,000 who are estimated to have fallen ill with TB. So in terms of actual notification only 409,000 cases were notified to the Department of Health. Okay, so that means we are missing 19,000 or 190,000 missing cases. Okay, in terms of proportion, you can see basically it's still a disease mostly associated among men, but let's not forget, of course, the children. Worldwide, TB is the top infectious disease killer in the world. So from 1.5, we now have 1.2 million deaths. So it is decreasing. However, it is still significant considering that we have this pandemic right now. There is an estimate that whatever gains we had in the past years, we would have an additional 400,000 people dying of TB in the next few months or in this year. So TB is the leading killer of people with HIV as well, and a major cause of death due to antimicrobial resistance. So these two actually should remind us to be very mindful of treating cases according to guidelines in order to avoid generating multi-drug resistant cases. So in the Philippines, it's the eighth leading cause of mortality. So last year we had 26,000 deaths. Now we have 28,000 deaths. That translates to 76 Filipinos dying from TB every day. Okay, so although there is a slight decrease in terms of the curve, this is partially because of the population that was previously estimated at 104 million and is now at 108 million. So treatment-wise, there was an increase in coverage from a previous of about 62%, I think. So we're now at 68%. And treatment success rate, however, is low at 83%. Our goal is, of course, to have a 90% coverage and 90% success rate. Okay. In terms of preventive treatment, there is a quadruple increase in terms of people receiving preventive treatment. So among HIV, sadly, this is just 54%. Among children, still a lot way to go. We only have 3.4% protected. But among households, household contacts, we are now trying to monitor this. We have 265 households that have actually received preventive treatment for being exposed to bacteriologically confirmed cases. You all understand that contact tracing is important in preventing transmission, especially in the household. That if we have a bacteriologically confirmed case, we need to actually take preventive treatment. Now, be mindful also of drug-resistant TB. So it's still increasing from a previous 18,000 estimate. We now have 21,000 estimates. About 7,500 were confirmed by laboratory, but only 6,000 are on second-line treatment. So in terms of the actual cases, so estimate has been going down over the years. So in the latest national prevalence survey, we have 1.8 or 2% of new cases being reported to have MDR. And among those previously treated, of course, with previous treatment as the greatest risk factor, so about 28%, we should be suspecting drug resistance among these cases. Now, we all understand that being a health worker is already a risk factor for contracting TB. So in 2012, there was a study from Dr. Benedicto and Dr. Jean Solante trying to measure the presence of latent TB infection among healthcare workers. Okay, this was done in about 10 tertiary hospitals. And they were able to note that reactivity is at 84.8%. So as a country, previous figures would cite that about 2/3 of the population would actually be reactive. Now, as healthcare workers, So there was an increase even at 84.8%. Now, each year there is a conversion of about 22.73%. Okay, so the odds ratio for developing LTBI per years of employment is at 1.12, and for age 1.03. So that means for every year that you've been working and every year that you are aging in that institution, you are further increasing your chance of actually contracting tuberculosis. Among those healthcare workers that were surveyed, it was primarily the nurses and nursing attendants that were found to be at greatest risk compared to medical residents. No consultants were included in the study, so we are not aware, and we might have a higher prevalence of LTBI if we try to include these consultants as well. Active TB, however, was low at 1.4%, but just the same, as healthcare workers, we are exposed to drug-resistant TB, and we need to actually be aware that even at that 1.4%, there is a risk of contracting a very difficult disease to treat. Now, this is partially related to the way TB is seen in the private sector. There is a study that came out 2 years ago in our Philippine Chest Journal, of which 118 physicians were surveyed in 2012. Now, the average number of presumptive TB cases seen is about 7 patients, and 5 of those are confirmed. In terms of the RTB, these doctors were said to see 1 to 2 cases weekly and 0 to 1 confirmed patients as well. Now, only 31% of the doctors would refer presumptive TB to other providers. That means that if you look at the last bullet, 95% in fact of doctors can manage presumptive TB. So this is good if we were to understand that there is a shortage of healthcare workers addressing our medical problems in the country. Okay. In terms of presumptive TB cases, you would see that there is more referring presumptive TB cases. These are the treatment cases. They are referred primarily to pulmonary and infectious disease specialists, whom they feel are able to deal with such cases. And then 96% referred MDR-TB. So you would understand that we have very few PMDT facility or programmatic management of drug-resistant TB facilities. So if ever, this is still highly appreciated that we are now heading towards each DOT center in the country, of which we have about 2,800, being trained to actually serve both the virgin cases and as well as the retreatment cases. Okay, so again, on the last bullet, you would see that only 6% admitted that they would be managing MDR-TB patients, and most likely these are the ones with training. Now, among those who were referred, so they said that DOTS was used in these patients in 85 to 94%. So 96% of those managing presumptive TB actually diagnosed it through the recommended smears and gene experts. I would presume during this time, experts were still on the rise. We only adopted it in 2011. So in 2012, it wasn't still as ubiquitous. Now, in terms of DITB cases, so a lot of people understood the need for cultures, but only 66% actually requested that. And then only half did drug susceptibility testing. So we understand that now with the gene expert on hand, we are able to diagnose immediately a surrogate marker for DRTB through the rifampicin resistance that we can simultaneously document through that test. So, in a sense, it's also a drug susceptibility test. So this is now part of the 2018 WHO guidelines in dealing with tuberculosis. The primary test is that of the gene expert, but for communities that don't have the gene expert available, so the TB lamp is also acceptable as an initial test over that of regular smear microscopy. Now, what is admirable is that 82% claim to prescribe the NPP standard regimen. But if you have 18% still not following the guidelines, this is still potential ground for harboring drug-resistant cases, particularly in those retreatment regimen. Only 72% would prescribe the retreatment regimen. During that time, we still have the category 2. Now, you understand that for all retreatment, we don't offer category 2 anymore. We give category 1, but of course, we have to diagnose through gene expert. So if you look at the variations, so a lot would just be repeating the first line drugs of varying durations. And then a lot would be adding fluoroquinolones, including ciprofloxacin, despite recommendation against its use. We are trying to reserve the fluoroquinolones because we want to use it as a second line agent. Now, for confirmed MDR-TB, for those who were actually managing cases, you can see that it also had variations in terms of what agent they will be using and in terms of the injectable duration. Okay, the ideal duration is 6 months, and you do not stop until you are actually having 6 months of negative cultures. So the entire duration range from 12 to 24 months. So you know that MDR treatment should be at least, well, there are short courses now at 12 months, but the usual then was about 2 years. So in terms of supervised treatment, 76% actually agreed to supervised treatment. However, this was not actually monitored, okay? But a lot of them would say it was a family member, a volunteer, or a public healthcare worker. Now, we need to understand that the risk of acquiring TB in our occupation is it's there. As early as the 2006 guidelines of the PCCP, PISMID, and PhilCat, there was already a section on health workers having a higher risk of contracting TB, about 13% in the ward compared to other areas in the population. So this is 40 times higher than the general population. So in fact, medical students were noted to have increasing prevalence of positive reaction each year compared to chemical engineers who do not. So it was greatest during their clinical training when they are exposed to actual cases with patients. Now, what are the reasons for this? Okay, well, I would say that there is less attention to infection control. We are all forgetting that TB is airborne, and that there is a need for us to understand that you cannot stop breathing, and therefore you would be most likely inhaling this air droplet-ridden, bacilli-ridden air droplets. There's also the increasing MDR-TB and TB-HIV cases. So if you have these, they will be more florid in presentation, and those that are immunocompromised, likewise, can have benign presentation. Now, transmission risk is highest when the patients have unrecognized TB or are receiving inappropriate treatment. And as I've mentioned in the previous section, so we do have a lot of these, of people not actually complying with guidelines. Now, the other considerations would be the healthcare settings. Is this the ICU? Is this the outpatient department? Is this the emergency room? Okay, so different sections of the hospital will have different risks, and therefore infection control plans should be tailored to the likelihood of encountering TB patients in this case. So occupational category likewise. So we all understand that aside from nurses, so doctors, respiratory therapists, and those in direct contact with cases can actually have a higher risk. It also depends on the individual susceptibility and immune status of each case. Okay. Adequacy of TB infection control measures, likewise, which is I mentioned as at the first bullet, is probably one of the most overlooked measures that we need to implement because we all have this false sense of security because we have not been contracting TB, that we are probably TB proof. Okay, I come across a case of one pulmonary specialist in India who all of a sudden was of course very confident in treating TB because we all understand that TB is curable. But if you have all of those MDR TB cases rolling around, of course, he eventually contracted MDR TB. And for him, that was already like a death sentence when he received the news. Okay. Because it required, of course, more complicated treatment regimen and more prolonged at that, with more adverse drug reactions. So just the same, we need to remember that we need to observe proper precautions. Now, it doesn't help that TB has stigma. Together with HIV, the combination of fear, denial aggravates diagnosis and treatment. There is actually an unspoken culture of don't ask, don't tell, so that you are not actually affected seemingly, okay? Because we are afraid of its possible career implications, particularly if you are a new hire or if you are occupying a high position. You wouldn't want to be labeled as someone as having such a very, I would say, low income group disease. Okay, that's how some people would look at it, because TB is a disease of the poor. Now, recently I came across a systematic review of TB incidents in low and middle income countries, and it was estimated that the annual risk of TB infection in healthcare workers ranges from 3.9 to 14.3%. Okay, so the average annual risk of developing TB was 3 times higher across all settings. So you always have to remember that we are at risk, okay? And that a delay in DRTB diagnosis, less effective treatment for DRTB, longer periods of healthcare contacts for DRTB, increase the potential of transmission to healthcare workers. So for DRTB, we are 6 times more likely to be hospitalized. Okay, so the main message is for us to all be careful. Now, more recently, there was a pooled prevalence estimate of LTBI among healthcare workers. So this is more global in nature. This was from the Open Forum of Infectious Diseases 2017. Now, this estimate is at 37%. And just the same, the odds ratio for contracting TB is 2.27. Okay, so the pooled estimate for active TB was 97 per 100,000 population. So the IRR is that of 2.94. So in essence, it's almost about 3 times more likely to contract TB, as mentioned in the previous slides. Now, in 2019, the US CDC actually updated the recommendations for LTBI testing, screening, and treatment. Okay, so in essence, the summary would say that there is a low percentage of healthcare workers now in the US having a positive TB test at baseline and upon serial testing. So now they recommend that there is a pre-placement evaluation for risk assessment, symptom evaluation, and testing if there was without TB or latent TB. but no serial TB testing in the absence of exposure or ongoing transmission. Let me repeat, this is only for the United States because they did not find it cost effective to be subjecting their health workers to annual or biannual testing with TST or IGRA. Okay. So, but the rest of the recommendations are basically the same. Okay. Now, when would a healthcare personnel be at an increased risk for TB? Of course, number one is not entirely applicable for us because our country is a high risk country or high burden country. But number two and three is applicable. So for those on immunosuppression with HIV, for an organ transplant patient, for on TNF alpha antagonists, for rheumatoid disease and others immunosuppressive medications. This has already been included in our most recent update of our clinical practice guidelines. Now, close contact with someone who has TB infectious disease since the last TB test is likewise part of the risk factor to be evaluated. I remind you again, in 2018, the WHO standard says that all contacts of bacteriologically confirmed cases should undergo latent TB preventive treatment with or without TST or IGRA. So comparing the 2005 to the 2009 recommendation, you would see that so it's basically the same that of TB screening of all healthcare workers for symptom evaluation, a test for IGRA or a TST, especially if they don't have a prior TB disease or LTBI. But the new one is to have individual risk assessment, of which I showed you the three conditions to look at earlier. Post-exposure screening, so for healthcare worker with negative baseline, so for them, no need to actually to do serial screening. But if you are exposed, you do a base and you have a baseline negative, you can have a two-step TST or IGRA 8 to 10 weeks after the last exposure. Okay. Now, evaluation of treatment of positive test result. So treatment is always encouraged for all healthcare workers with untreated LTBI unless medically contraindicated. Okay. I know that in our country, this is not entirely practiced in as much as we keep on waiting for symptoms before we actually treat for TB. Okay. But remember that we now have more effective preventive treatment. No? Aside from the INH of 6 to 9 months before, 9 months being preferred for those with HIV, we have the daily rifampicin of 3 to 4 months as one of the more acceptable regimens, even to the Department of Health. So you can have an INH rifampicin combination, rifapentin, the last row, for weekly for 3 months together with INH. Rifapentin is still being procured by the Department of Health. We are not yet sure about its availability at present. So, in this section, I'd like to focus on policies on systematic screening as mentioned by the National TB Control Program Manual of Procedure 6th edition. This came out last March. So we know that systematic screening shall be implemented in all health facilities. When we do symptom screening, we are looking for the 4 cardinal signs and symptoms, and that is at least 2 weeks of cough, unexplained fever, unexplained weight loss, and night sweats. So this will be our primary screening tool. When before we were just looking for a cough of 2 weeks before we evaluate the patient or an X-ray finding. Now, basically, you can have any of these symptoms as an offshoot, as a takeoff point for evaluating your patient. So this came out from the latent TB guidelines of WHO in 2018. It said that since this was being used actually to rule out active TB, it has a sensitivity of 79%, a specificity of 50%, a negative predictive value of 97.7%. Imagine that, at a TB prevalence of 5%. Okay, so even in low prevalence country, so this is a good way of screening for TB. So they use chest X-ray annually among all health facility consultations, that is the patients. Active case findings shall be implemented in congregate settings, using X-ray as the screening tool and expert as the diagnostic test. I did mention earlier that the TB lamp can also be considered, particularly for new cases because only 1.8% are actually MDR, and the TB lamp is another PCR-based test anyway. So it's also very reliable. So all people living with HIV shall be screened for TB. We know that, but now the more progressive policy now is that all health facilities shall screen its worker for TB annually using both symptom screening and chest X-ray screening. So if you notice, in the Philippines we are not using TST or IGRA for screening even those that have been exposed. Okay, so let me remind again, particularly the infectious disease fellows and trainees, that we don't use TST or IGRA for diagnosing active TB. Okay, so but I do appreciate the consultations. Household and close contacts of all ages shall be screened for TB using the symptom and X-ray as well. So these are just algorithms on what to look for. So any of the four symptoms. So if none, you can do a chest X-ray. If the chest X-ray is suggestive of TB, then you work up the patient for gene expert as a presumptive TB. And as I've said, but any sign of the following, you can have already a, a gene expert test if you have any of those symptoms. This is because we're trying to increase our case finding. We are trying to look for, I believe, 5 million by 2022. And so far, we are much delayed at by 3 million, I think. For those with HIV, basically you have the same, but this is in combination with an X-ray. So any of the symptoms and or an X-ray suggestive of TB, we will be subjecting the patient for gene expert. Okay. Then every visit thereafter, we are to reevaluate for the presence of symptoms. For health workers, so this is just a summary. We do baseline screening using the symptom screening and X-ray, and then follow up with just TB symptom and an X-ray annually. Okay. So the topic includes prevention. So I'd like to focus on infection control at this point. Okay. So we need to identify and strengthen our infection control committee and infection control team within our facilities. There must be an available IC plan, okay? So oftentimes this is neglected by big institutions. However, in UST, we have our own Committee on Hospital Infection Control. Okay, we just need to actually align our policies with new developments, particularly with the pandemic. So now we need to evaluate the presence of TB and COVID-19 simultaneously if available. Of course, if we have our own gene expert in the future, we are able to conduct our gene expert test likewise to test for COVID. Okay, so we have to rethink our available spaces. in making try to make full use of available spaces that are not crowded with good ventilation, and then we assess the facility itself for waste disposal, for patient segregation. We conduct surveillance of TB disease among the workers themselves. We do advocacy, communication, and social mobilization sessions for health workers, patients, and visitors. Everyone needs to be aware of cough etiquette, of hand washing, of patient segregation, and then you monitor and evaluate its implementation. Of course, research effort every now and then can help improve our infection control. Administrative controls would mean that we need to identify people with TB symptoms as early as that I just mentioned. We need to segregate, separate them, enforce cough etiquette, minimize their time in the healthcare setting. So we have the fast approach. That means we are able to uh, process a TB patient within 1 to 3 days, immediately, less than 1 week before we start treatment. So the goal is that within 2 weeks, the patient already must have already received treatment. In the Philippines, particularly in a study we did in Pangasinan together with the, I believe with the clerks before, we found out that it took about an average of 19 days before they are actually able to be started on treatment. And some even went beyond 2 years before they actually started on treatment. So these are all deplorable. So the idea is to have infectious patient treated immediately within a week if possible. You all understand that the most important infection control measure is, of course, treating them with appropriate regimen immediately, because in as short as 1 to 3 days, the TB bacilli load of a virgin case goes down to about 90% the pre-treatment level, and then in 2 to 3 weeks time it will be about 99% the pre-treatment level. So in smear negative cases, so it can be non-infectious in as short as 5 to 7 days. Okay. So we need to provide a package of TB prevention and care for health workers, including HIV prevention, especially for, we're not so sure, of course, because of our policy of non-disclosure, but for HIV health workers, they should be provided antiretroviral therapy and INH preventive therapy and other preventive therapy for LTBI in order to protect them from tuberculosis. So the first consideration is always block the first step in the pathway of TB transmission, stop it at the source, prevent the release of droplet nuclei in the first place, and this has been very effective. So we can do this, of course, by the segregation as mentioned, by identifying those patients, by minimizing their time, and at the same time observing cough etiquette. So we try to improve diagnosis with an early and rapid diagnosis. So we need to have rapid tests, reduce laboratory turnaround times. If smear negative, we carry out further diagnostic tests in parallel rather than sequentially, okay? So I know that previously we were recommending the smear and then the chest x-ray. So of course it was more practical to have both done immediately. So as mentioned, prompt initiation of appropriate TB treatment is important. And if you are suspecting drug resistant, be sure to request for the appropriate tests. So gene expert, of course, in culture and drug sensitivity testing. So this is just a summary. Identify people with TB symptoms, separate the infectious cases, ensure patients cover their cough, minimize time in health facilities, and of course, protect our health workers. In terms of environmental control, we need to reduce the concentration of infectious particles in the air via ventilation, which could be natural, mechanical, or mixed mode. So we need to be aware of the direction of the airflow and trying to avoid disruption of the unidirectional laminar flow of air. We can use ultraviolet germicidal irradiation, okay, through your black light directed upwards. Of course, nowadays we have the HEPA filter, but quite expensive. But of course, since it's being more ubiquitous now for the COVID protection, the area of interference though for such would usually be around 6 feet from the um, unit itself. So you would require several units if ever. So this can probably be further aided with the use of serial exhausts and mechanical ventilation to help improve airflow. The airflow is ideally about 12 air exchanges, especially in high risk facilities. So in areas where we do bronchoscopy, we do consultations, like in the in the DOTS facility. So we need to make sure that there is proper airflow. Okay. So you need to locate the health worker nearest the clean air source. Remember that. Locate the person who may be infectious in a place where the air is exhausted away. Demonstrating it, you can see that the healthcare worker is nearest the air source while the patient is towards the exhaust. Okay? So it's incorrect if it's the opposite. You are likely contract TB by having this arrangement. A possible compromise would be perpendicular, I mean parallel, okay, wherein both of you are facing each other, but the wind direction is going towards one direction. So opening on opposite walls or cross ventilation allows a unidirectional laminar flow of air. Okay, so you should be able to offer about 10% of the floor space should be a window area on opposing walls. Okay, so make sure that the openings are unrestricted. Okay, so try to remove uh, curtains, blinds, which might impede the airflow. Okay, but I understand, of course, that this might not be practical, particularly in dusty NCR. Okay, high ceiling is very nice because, of course, you understand that the warm air, especially the exhaust of patient, goes up. Okay, building openings are oriented to use the prevailing wind, so do not try to design your facility with an opening that goes against the usual wind direction. And always be mindful to avoid short circuiting. Okay, you might have an exhaust in your facility, but it is very near the aircon or the air supply. So clean air is removed almost immediately upon entering the room. The cleanest area would be the one in this red where the red arrows are, and on the opposite side would be the ones with the poorest air quality. So as I've said, it should be on opposite sides of the wall. Lastly, we are very much familiar already with the importance of personal protective equipment. So if we can control the quality of air with the administrative and environmental controls, so the PPEs would be the one that we will be using to protect ourselves. So in situations where there is an increased risk of TB transmission, we need to be using N95 masks. And of course, we need to do fit testing so that we are using the proper size mask for the type of face that we have. Don't forget to press on the metal clip in order to make it fit snugly in your face. That's all. Thank you.
Thank you. Thank you very much, Dr. Morfe, for that very informative lecture. It's about time that we talk about healthcare associated shade. So, there's a question po at the chat box by Dr. Nini Santos po. So, in laboratories, doc, which don't use their PCR machines for SARS-CoV-2 diagnosis, is there a need for a negative RT-PCR prior to running the gene expert? If yes
Can,
po, how long from the negative RT-PCR
can you please
should it
repeat the
be
question?
done?
You were choppy.
Ay, sorry po,
The
doc.
question, you were choppy.
Okay, I will repeat the question po. So, The question by Dr. Santos, Doc, is in laboratories which don't use their PCR machines for SARS-CoV-2 diagnosis, is there a need for a negative RT-PCR prior to running the Gene Expert? And if yes, how long from the negative RT-PCR for SARS-CoV-2 should the test be done po?
Actually, when you put the specimen inside the cartridge, I do remember that there is minimal what's this disturbance of the specimen actually. So, but of course, it would be appropriate to use gloves for handling specimens, and at the same time to use N95 mask. Usually, they do this in a hood. Okay, when they try to handle TB specimens. It might be hard to actually require the use of a negative pressure, particularly in rural health facilities. So that's why we recommend merely the opening of the exhaust machines in order to make sure that there is good airflow and that the laboratory personnel are wearing PPEs, the proper masks to protect themselves. So, but if they have that, if they have the HEPA filter, for example, or a negative pressure type of feature for the facility, then it would be best that they take advantage of that and might as well. Okay, but if you look at the literature for Gene Expert, they will tell you, WHO will tell you that there is minimal generation of aerosols from handling the specimens because it is an enclosed container actually once you transfer the specimen.
Okay, thank you very much, Dr. Morphe, for your answer. Doc, I have a question po. Are there PhilHealth or SSS benefits available for our healthcare workers who acquire healthcare-associated TB?
The same. It is covered by the TB benefit package for regular patients. For as long as you are a PhilHealth member, you are compensated about I guess about up to 2,000 pesos, I think, for the initial. For if you're able to complete treatment, up to about 4,000. I know it is very small compared to what you might actually be spending for your treatment, but you know the TB diagnosis and medication is actually free in government centers. Now, in private institutions, I know this is part of their collective bargaining agreement, and they can get free medication, free laboratory testing. So, I'm not so sure exactly if they can still claim for PhilHealth, unless, of course, these are individual applications, because otherwise it has to be under a DOTS program before you're able to claim for TB.
Thank you very much, Doc, for that clarification. And if there, I think there are no more questions from the chat box. With that, we would like to thank Dr. Morte and would like to present the certificate of appreciation for having lectured to the 17th postgraduate course Science and Performing. Thank you very much for
Thank you as well.
we shall be having our 10
So,
minute coffee and physiology break. See you all in Hello everyone, let's resume our program. Let's call on Dr. Marañon and Dr. Sanchez who will be our moderators for these next two sessions. Our next speaker completed his education and training at the University of Santo Tomas. He is a member of the Philippine Society of Experimental and Clinical Pharmacology and is currently the Secretary of the Department of Pharmacology of the Faculty in Medicine and Surgery of UST. He is the current chair of the Department of Medicine at Perpetual Socorro Hospital and is a board member of the Philippine College of Chest Physicians. Colleagues, I present to you the versatile and assiduous Dr. Jude Gia.
Good morning, Tina.
Good morning po, Doctor. We are
Okay,
excited
so
for your lecture.
grabe.
Marami
So,
pong nagtatanong tungkol sa vaccination during this time.
okay. So, Tina, can you see my slides?
Not yet po, Doctor.
For a while.
Yan, Doctor, we can see the slides. There, Doctor. Okay.
Okay. So, can you hear me, Tina?
Yes po, loud and clear, Doctor.
Okay, so good morning, everyone. So, wait, I'll share my video. Hindi ata ako nakikita, no?
There, we can see you na po, Doctor.
Yan, okay na. Nagulat ba kayo?
May apparition po.
Apparition. Okay, so good morning. So my task for the next 30 minutes is on adult vaccination, especially in times, no, during this time of pandemic. And these are my learning objectives for the next 30 minutes. And this is the manner wherein I will deliver the lecture. So basically, so this is my outline of the talk. So for the information of everyone, August is celebrated as the National Immunization Awareness Month. And for the PCCP advocacy, wherein I am a member, so we conducted watch parties or lay fora pertaining to the common immunizations available in the Philippines. And likewise, we celebrated World Pneumonia Day last November 12, and through the efforts of our colleagues in the society and in CRM, Dr. Eric Moral and Dr. Earl Sempio, wherein they conducted tweet chats, no, from the Phil Pulma group. So basically, this is a way of informing the public about the occurrence, the prevalence, and how do we treat pneumonia, coinciding with the National Awareness Immunization Awareness Month on the common preventable diseases, no, wherein vaccines are very effective. So vaccination is still one of the most effective tools that play an important role in adult health, and it saves millions of lives and is widely recognized as one of the world's most successful and cost-effective health interventions. They are safe and cost-effective, and the vaccines are effective against some common diseases that have been shown to dramatically improve health and quality of life. A study in the United States were in around 550,000 American adults who die each year due to diseases that could be prevented through immunization. As population age globally, we are seeing an increasing burden of vaccine preventable diseases in adults, no, because age increases the risk and severity of infectious diseases, especially when chronic diseases are present. And it is important to ensure that increasing lifespans are matched with increasing health spans. Therefore, a good coverage is important, even though studies have shown that low vaccination coverage rates for many routinely recommended adult vaccinations still exist, no, even in countries where there is a good healthcare system. So this is a data in 2017 from the DOH showing to us the leading causes of death. And still number one is the ischemic heart diseases. But take note that pneumonia ranks fourth, and your chronic low respiratory tract and respiratory TB ranks around six, no? Six and seventh leading causes of mortality. So what about morbidity? So again, number two is pneumonia, and number six is influenza. Okay, so which mostly affects around 2.4 million Filipinos. Okay, so this data shows that these two illnesses, rather, the pneumonia, influenza, are preventable, and no individual, regardless of age and social status, should die or get sick from a vaccine preventable disease. So vaccination are not just for kids. Okay? So adults can be protected from the 14 deadly diseases, okay? Particularly from influenza and pneumococcal disease. However, low vaccine coverage in adults reflects the fact that adult vaccination has not been fully, or rather has not been a priority the way pediatric vaccination does. Okay, and many of the vaccines recommended for adults don't work unless you get them into the arms of the people who need them. And adults are uniquely, or rather unlikely to seek, no, unlikely to seek vaccinations unless they believe that the disease is a threat to them and that there is a vaccine that can prevent the disease. So what about the economic burden of adult vaccine preventable diseases? Okay, so healthcare is facing serious challenges in terms of access and affordability issues, and of course, underutilization of healthcare prevention. Vaccines save thousands of lives, but many adults remains unvaccinated. The estimated, or rather the unvaccinated, is responsible for around 80% of the financial burden, as this is based on a US study, so that's around an equivalent of $7.1 billion. And the preventable diseases usually results in cost to individuals and society, mainly increasing their health expenditures, lost income, and of course, that also includes the visits to the doctors. One issue pertaining to economic burden is vaccine hesitancy, which will I discuss later on. And of course, some healthcare providers, no, unfortunately, they prioritize some vaccines over the other vaccines, especially if, for example, the brands, no, they're pertaining to brands are not available during that time, they will recommend, no, to other to patients other vaccines rather than the scheduled vaccine for that particular year or to that particular visit. So while the majority of pathogens prevented by vaccines cause acute infections, we can see here in the study by Ozawa that pneumonia, including hepatitis and herpes zoster, okay, are causes of several delayed and chronic complications contributing to a high unit cost. And based on this study, the total current economic burden is estimated at approximately $8 to $9 billion. This was in 2015 and was published in 2016 from vaccine preventable diseases. And Additionally, this data reflects that majority of the estimated burden was for direct cost and for inpatient and outpatient treatment costs. So the WHO released 10 threats. No, I think they published these 2 years ago, wherein they mentioned the 10 threats to global health, no, in 2019, and one of which is vaccine hesitancy. So what is vaccine hesitancy? So this refers to delay in acceptance or refusal of vaccines despite availability of vaccine services. Now, vaccine hesitancy is complex and context specific, varying across time, place, and the particular type of vaccines. And usually, vaccine hesitancy is influenced by factors such as complacency, convenience, and confidence. A study conducted by Laughlin regarding the barriers to vaccination, which is under vaccine hesitancy, shows that there are three barriers with regards to vaccine hesitancy. So we have the patient barrier, provider issues, and system level. So with patient barrier, we can see here that there is lack of awareness of the need for the vaccine, lack of recommendation by the health provider, there's fear of side effects, no, or a busy schedule of the patient, and lack of belief that receiving the vaccine is wise. And of course, patient attitude. No, we usually see this in our patients. However, um, no matter how we convince them, some of our patients refuse to be vaccinated. So what about provider issues? Okay, so the belief of the doctors percent. No? So because some of our doctors don't believe um, in vaccination, okay, or an issue regarding some doctors does not stock vaccines in their clinic, and or there's a failure of the doctor as champions for adult vaccination. Okay, so again, mind you, this is a U.S. data, and the system level. So this corresponds to the vaccination availability in terms of where to keep the vaccines, or having a central pharmacy for vaccine procurement, or not stocking vaccines in the individual clinics, and lack of reminder and tracking system. So I think this is very important, the tracking system, wherein we need to really um, recall this, really need to check, no, whether our patient is really receiving or getting the appropriate vaccines. So one way to address to the system level is through a vaccine app. No, so this is being used in the United States, wherein they track, no, they track the records of patients. Okay, so what are the vaccines that the patient has already uh, received for the past months, or does the patient receive any form of vaccination either before 65 years old or after 65 years old? Because in order to address the barriers, we need to understand the underlying factors, okay, associated with each specific barrier. So whether it's patient related, doctor related, or administration or system level related. So I will focus on the one of the two common preventable vaccine diseases, vaccine preventable diseases, which is influenza and pneumonia. So this is the data, okay, provided by the DOH, okay, about the monthly surveillance report on influenza. So this was released in 2019, the first half of 2019, and shows that there is a high rates of influenza-like illness in the months of January or February. So that's the about the peak, of the burr months in the Philippines. Regarding the data for the second part of 2019 is not yet available, and data for early 2020 is not yet available also, no, because of the pandemic. Most probably the testing, the test is directed towards SARS-CoV. We all know that the manifestations of influenza and SARS-CoV was basically almost, basically the same, meaning the clinical presentations. So, based on the 2019 report from the DOH, the influenza pathogen is a major cause of severe acute respiratory infection in the Philippines, or SARI. So you can see here that in 2018, the most prevalent pathogen for influenza is influenza A. Around 29% of all specimens submitted for testing shows high yield for influenza A, and around 7% for influenza B. So again, the initial data for 2019 regarding SARI causing, influenza causing SARI, around, for the first part of 2019, around I think 8 to 9% based on 580 specimens submitted. And as of now, there's no available data for the second part of 2019 and early part of 2020. Again, because of the pandemic, most probably focusing on the diagnosis for SARS-CoV-2. Okay, so what about laboratory surveillance information, particularly the Philippines? So this is based on the data from GISRS, which is the Global Influenza Surveillance and the Response System. And the main mission of this organization is to protect the people from the threat of influenza by continuously functioning as a global platform for monitoring influenza epidemiology and disease. So you can see here that in the early part of 2019, there is a prevalence of the influenza B lineage strains, no, particularly involving the two lineage strains for influenza B, which is the Victoria lineage and the Yamagata lineage. And the latter part, or the second half of 2019, you can see here that the predominant pathogen is more of the influenza A, no? The H1N1 and the H3 strains. Okay? Although there are also um, pathogens, no, pertaining to the influenza B, no, but more of the A on the second part and B on the first part. So this might have this might be meaning this might what's the implication of this? No? So we might be we might think, no, of the type of the vaccines we're going to administer to our patients, whether we're going to give a trivalent or a quadrivalent vaccine. Although there's no head-to-head studies comparing the two, but I think the trend now is that there will be more of the quadrivalent vaccine available rather than the trivalent vaccine, because the trivalent vaccine contains only one influenza B lineage depending on the WHO recommendation, while the quadrivalent vaccine contains both, no? The influenza B lineage, which is the Yamagata and the Victoria lineage. What about pneumonia? Okay, so as we know, the incidence of pneumonia increases as the age increases, and there's the presence of comorbidities. Okay, so you can see here in this slide that the presence of diabetes, the presence of chronic heart disease, and the presence of chronic lung disease increases the risk of having invasive pneumococcal infection 3 to 6 times, no, in these three subgroup of patients. So these are patients who are at high risk and who we should prioritize in giving them vaccinations. Now, one issues that we usually encounter among our patients is vaccine safety. No, so are vaccines safe? That's the most common questions that our patient ask whenever we recommend, no, the administration or the giving of vaccines. Okay, so how safe are vaccines? Okay, so vaccines is the one of the safest. It's one of the safest interventions in public health. No, and like any medicine, it can cause also side effects. No, but usually minor and self-limited. Now, even though it may cause severe and long-lasting side effects, although some are rare, Okay, it's very important that we need to monitor and surveillance. No, it's important also after immunization is administered to our patient. And sometimes patient will ask us, why do you need to give combination vaccines? Okay, so will it cause me more harm? Okay, then I'm going to get or I get prevention, no, from pneumonia or influenza. Okay, so receiving combination vaccines, okay, or multiple vaccines are at the same time are safe. Okay, so later on we will discussing, no, the simultaneous, okay, vaccination. And it is important that patients should be informed, no, of the potential and common adverse effects prior to vaccine administration. And of course, we need to give instructions to our patient what to do should they experience some form of adverse event. Therefore, to promote vaccine safety, communication is very important between the doctor and the patient. And we also need to emphasize to our patients that vaccine safety crises are rare. Now, this is taken from the guidelines from PISMI, no, regarding issues on safety. So I think as physicians or as healthcare providers, we should know the difference between contraindications and precautions in terms of vaccine administration. So when you said contraindications, so these are conditions in a recipient which greatly increases the chance of a serious adverse reaction, and therefore it should not be administered or should not be given. Examples of which includes the MMR, should not be administered in severely immunocompromised patients or those patients with severe allergic reactions to a vaccine component prior to a dose, and of course the presence of encephalopathy, which is not due to other identifiable causes, okay, especially those patients who receive pertussis vaccination. And when we say precaution, so these are conditions in the recipient which may increase the chance of severity of an adverse event, and this could cause, no, diagnostic confusion or might compromise the ability of the vaccine to produce immunity. So examples of precautions, you have your measles vaccine to patients with passive immunity to measles as a result of blood transfusion, or those patients with moderate or severe acute illness with or without fever. Okay, so we should be very careful in giving these vaccines, or yeah, the vaccines. So this slide shows to us the conditions commonly misperceived, so as contraindication and precautions or precautions. Okay, so like mild to moderate local reaction, mild acute illness, or the convalescent phase of illness, or the patient is currently on antimicrobial therapy. So this means that even though these are present in your patient, okay, so you may still can administer the uh, uh, the vaccine due for the patient. Okay. So whenever we have patients for vaccination in our clinic, it is very important that we screen our patients for contraindications and precautions to vaccination prior to vaccine administration. So these are simple questions that we need to ask our patients. Okay, so you can read this in the PISLID guidelines and in the CDC guidelines. Okay, basically they are the same. So you need just to ask your patient, are you sick today? Are you having fever? Are you having sore throat? Or do you have any allergies, particularly to egg? Okay, have you had a serious reaction to a vaccine in the past? Okay, or do you have any history of seizures or nerve problems, or having experienced or experiencing some form of a neuropathies? And do you have any comorbidities? Are you obese? Are you diabetic? Are you asthmatic? Okay, so these are some sample questions. Or have you been in taking, or rather on treatment for, let's say, a malignancy, meaning are you on chemotherapeutic agents, or do you have any other immune system problems? Are you taking steroids, okay, or had X-ray treatments in the past 3 months? Do you see X-ray treatments? Meaning, I think this is about radiation therapy. No? So, did you receive blood transfusion or any blood products? And of course, the pregnancy is very important to us. Are you pregnant? Okay, or is there a chance that you could get pregnant during the next month? especially during the influenza or the flu season. Okay, and have you received any vaccinations in the past 4 weeks? Because timing of vaccination is very important. Okay, now if for example the patient says yes to any of these questions, then further evaluation is needed before administering a particular vaccine to a patient. Okay, so these are just examples, okay, of the of contraindications, precautions, and adverse events for each vaccine. So I will not be discussing each and every vaccine, but I'll be just giving you the contraindications and precautions with regards to influenza vaccine. Okay, so you have severe allergic reaction and moderate to severe acute illness, or is there any history of GPS? And we inform our patients that the most common adverse effect is problems or pain, no, in the injection site. No, there will be local tenderness and soreness. For pneumococcal vaccine, so contraindication or precaution is anaphylaxis to any vaccine component or a previous dose of a vaccine. And we need to tell our patients that the common adverse events after pneumococcal administration is redness, swelling, and soreness of the injection site. And they could also experience fever, malaise, and muscle pain, and of course, some form of allergic reactions. Okay, so for tetanus, diphtheria, pertussis, okay, so these are the contraindications and precautions and the rare, no common adverse event for tetanus. So what about timing and spacing of vaccine? So to optimize maximum benefits from vaccine, the recommended schedule should be followed as closely as possible. Okay, and vaccine doses should not be administered at intervals less than these minimum intervals. Okay, and doses administered too close together or at an age younger than the required age can lead to a suboptimal immune response. Okay, so simultaneous administration of vaccines is allowed on same clinic day, given at different anatomic sites, but not combined in same syringe, because this will increase the yield of the patient, or rather, this will increase the opportunity rather of the patient to be vaccinated on that particular time. So we allow simultaneous administration. For any inactivated vaccine, this can be administered either simultaneously also, okay, or at any time, okay, before or after a different inactivated live vaccine, okay, inactivated or live vaccine, okay. So, however, exception is with regards to your PCV13 and your meningococcal conjugate vaccine, because these two vaccines should be administered uh, 4 weeks apart, okay, to prevent reduction in antibody concentration. Now, for live vaccines, no, so two live vaccines should always be administered on the same day. Otherwise, should be separated by more than 2 weeks, not to minimize the potential risk for interference. If two vaccines cannot be administered on the same day, so especially depends on the availability of the vaccine. So you space it within 4 weeks. Except for yellow fever vaccine, which can be given less than 4 weeks after an MMR or a varicella vaccine administration. Okay, so there are two types of pneumococcal vaccine available in the Philippines, and these vaccines are serotype specific to cover for those frequently associated with severe illnesses. Okay, the invasive pneumococcal disease. Your serotype or your PPSV or your PSV23 contains 12 serotypes in common with PCV13, and there's an additional 11 serotypes for which there are no indirect effects from PCV13 use in particularly in children. And the addition of the 11 serotypes accounts for about 32% to 37% of invasive pneumococcal disease among adults age 65 years old. Okay, so I think you're all familiar with this. Okay, so the difference between a PCV13 and a PPSV23 serotypes. Okay, so the 13 serotype can be used for all ages, while the 23 serotypes can only be used among children above 2 years old and the all adults. And the protection is longer with the 13 serotypes and shorter for the 23 serotypes. However, the 13 serotypes stimulates your T cell immunity and likewise induces mucosal immunity, and there's a good effect on there's an effect no, on the nasopharyngeal carriage. And of course, we know that the 13 serotype is much expensive or more expensive compared to your 23 serotypes. With regard to pregnancy, so there's no published recommendation, but later on I will be discussing to you uh, the recommendations of these two vaccines in pregnant patients. So another way to compare the properties of the vaccines, the two vaccines, is that um, the your PCB13 exhibits herd effect, no, comparing to your PSV23, which does not exhibit herd effect, no, meaning herd immunity. So what are the guidelines with regards to pneumococcal vaccine administration? So this is the 2018 CPG, or the clinical practice guideline, taken from PISMID. Okay, so for adults and elderly with no history of pneumococcal vaccine, so ideally we give PCV13 first, followed by your PSV 23 at least 1 year apart, and no revaccination with both vaccines, no, with both pneumococcal vaccine is needed. So just remember the 1 year interval for both the PCV13 and PPSV 23. Okay. Now the cutoff for Filipinos is 50. Unlike in the United States, the cutoff is 65 because the Filipino lifespan, no, is shorter, okay, compared to the uh, 65 years old recommended by the CDC. So for adults less than 50 years old, and these patients are previously vaccinated with 23, no, your PSV 23, who are now more than 50 years old. So you give your PCV 13 first, followed by your PSV 23 at least 1 year apart. Okay, so again, 1 year interval. So this for patients below 50 with previous vaccines for 23 who are now more than 50 years old. Now, for adult patients who are more than 50 years old and they were already given PSV23, so again, the recommendation is to give their PCV13 at least 1 year, no, from the last dose or from your previous dose of uh, your PV23. Okay, so that's 1 year apart. And for adults more than 50 years old and previously received no PSV23 without prior PCV13 vaccination, so you just give one dose of your 23 after 5 years. The 5 years after from the time that the patient received initial vaccination of PSV23, and no vaccination or no revaccination thereafter. Okay, because studies have shown that there is no increase in the antibody titer with revaccination or with multiple booster dosing. Now, for patients who are immunocompromised, okay, meaning these are patients who are at high risk of developing invasive pneumococcal disease, sequential vaccination of PCV13 and PSV23 is recommended. Okay, so these are the conditions, okay, wherein sequential administration is recommended. Okay, as you can see in this slide. Okay. So what about the CDC recommendation, okay, in special situations for the use or the administration of pneumococcal disease. So this is for adults 19 to 64 years old. So if the patient is a smoker or has a chronic condition, as seen in the slide, then you just administer your 23 vaccine, okay, your pneumococcal vaccine. However, if your patient is between 19 to 64, but they are immunocompromised, okay, like for example, they are HIV patients or they are on dialysis, okay, they have nephrotic syndrome and a splenic, these are example conditions, then the recommendation is you administer first your PCV13, then after 8 weeks, you inject them with your PSV23. Then after 5 years, you give them another shot of your PSV23. Okay, so this is the one condition wherein revaccination of PSV23 is recommended. Now, for those patients with CSF leaks, no, or those patients who had cochlear implants, okay, so the recommendation is you administer first PCV13, then after 8 weeks, you give them your PSV23 and no revaccination thereafter. What about those patients above 65? So if they are not immunocompromised and no history of previous vaccination, then you only give PSV23 to these patients. Now, for above 65 and giving them PCV13 is a shared decision making, okay, because um, the prevalence of disease caused by PCV13 serotypes is low. Okay, therefore the expected benefit of the additional vaccination is also low. But in case the patient decides to be given PCV13, then you administer the 13, then after 1 year, you administer the dose of your PSV23, okay? And if the patient has or is high risk, then you give earlier, which is within 8 weeks. But again, for patients above 65, not immunocompromised, and no history of pneumococcal vaccine, you administer only PSV, your PSV 23. And as I mentioned, okay, shared decision making is needed if the patient wishes to be administered, or to be given with PCV 13. Okay, so what about high-risk adults, okay, above 65, okay? So again, we need to ask the history of our patient, okay? Is this patient below 65 and previously received PSV23? If yes, okay, you give your PCV13 a year after, followed by 1 year from the time the PCV13 was administered, you give your PSV23, and earlier if the patient is higher risk. Okay, and for those patients who previously received PSV23 at age 65, okay, so you just give your PCV13 1 year after, okay, the from the time that the patient received PSV23. Okay? So before age 65, you give them PCV13. If previously vaccinated with 23, then revaccinate, okay, with PSV23 after 1 year, and that's it. Okay, no more revaccination. And for those patients who are at the age of 65 and above, with previous PSV23 injection, then you give 1 year after the administration of your 23, your PCV13. Okay, so the reason why we prefer to give the 13 before the 23 is because of this. Okay, we all know that the conjugate vaccine stimulates T cells. Okay, to be able to help the B cells produce antibodies and generate immune memory. Because with the polysaccharide vaccines, it only stimulates the B cells not to produce antibodies. Okay, so this is the rationale why it is recommended to give first the PCV13 before the PSV23. Okay. So what about the flu vaccines? Okay, so we have two available types of influenza vaccine. We have the trivalent and quadrivalent. Okay, so I think I already discussed this earlier. There are two strains for influenza A covering for H1N1 and your H3N2. And it contains one influenza B virus depending on the prevailing WHO recommendations. While for the quadrivalent vaccine, it contains four influenza surface antigen covering not only for H1N1 and H3N2, but also for both the influenza B lineage. We have the Victoria and the Yamagata lineage. So this is the PISMID recommendations regarding adult immunization schedule. So from the previous guidelines, you can see here that the age ranges has been reduced, no? Uh, from 19 to 26, 27 to 49, etc. Because this is due to the change made to recommended catch-up, okay, vaccination, especially for HPV vaccination for all adults from 26 years old and above. Okay, so for influenza, one dose yearly as early as February. Then for pneumococcal, one dose, okay, initially PCV and one dose after you give your PSV23. Okay, so these are also recommendations for other preventable diseases like your meningococcal. Okay, now your aged influenza is not routinely given except for splenic individuals. Okay, so ideally we give them the vaccine. Okay, as recommended prior to the surgery, prior to splenectomy. So what about healthcare workers? Okay, so it is important also that we provide the immunization to our health workers, especially the first line. So this includes your barangay health workers, your pharmacists, doctors down the line, including students on clinical rotation. And it is strongly recommended that they receive your DPT, Hepa B, influenza, your varicella, and your MMR, and also that the first line workers should receive polysaccharide, the pneumococcal polysaccharide vaccines, and your rabies and meningococcal vaccines is recommended only for selected healthcare workers. Okay, what about the second line? So this includes your personnel and the other personnel in the hospital. So also it is strongly recommended that you administer, okay, your influenza, your varicella, your hepatitis B, and your Tdap vaccines. So these are the recommendations on immunizations of healthcare personnel, with special conditions, meaning those are pregnant, those with HIV, okay, those with kidney failure, etc. So across the spectrum of healthcare workers, including your pregnant patients, so we give one dose annually of your influenza. Okay, for your pneumococcal vaccine, okay, so we don't recommend PCV13 for pregnant patients, although mostly in the literatures, there is no contraindication for giving this to pregnant patients. But to be safe, you give the vaccine on the second and the third trimester pregnancy. Okay. So what about immunization in the context of COVID-19 pandemic? So this data is taken from the Pan American Health Organization, which was published in 2020. So this is a guideline with regards to immunization programs, okay, meaning the administration of vaccines. So there are three clinical scenarios. So the first scenario is that if the capacity of the health system is intact and the provision of essential health services is continued, then the vaccination program should be conducted through fixed points, or mobile posts, and should be given to priority individuals. Or if no, when only limited services is provided, then we prioritize vaccination in vulnerable populations, no, with emphasis on influenza vaccines. And if vaccination cannot be provided, performed safely, and there's the risk of SARS-CoV-2 transmission, then we suspend or defer vaccination until such a time that the risk of transmission of SARS-CoV-2 has been reduced. Okay. So patient may ask, is adult vaccination, okay, recommended during the COVID-19 pandemic? Okay, so the answer is yes, no, because existing vaccination programs for older adults and individuals who are at high risk, no, should be maintained while implementing, okay, measures to avoid the spread of COVID-19, especially those patients who are at high risk. Okay? So preventing respiratory illnesses, likewise, it reduces, no, the risk of transmitting, okay, and infecting the healthcare workers, which are important, okay, in the manpower, no, as manpower in the hospitals. Okay. So once these health workers should be vaccinated, okay, so to be able to support, okay, the COVID-19 patients. Okay. What about persons with confirmed or suspect infection? Can they be vaccinated? Okay, so the answer is yes. And until today, there are no known medical contraindications in vaccinating persons who have COVID-19. If the person or that particular patient, no, who wants to be vaccinated, okay, is not in a healthcare facility, meaning just at nasa bahay lang siya, no, uh, the act of seeking immunization may increase spreading infection to others. Okay, for this reason, this individual should defer vaccination until symptoms resolve or preferably following, okay, um, negative test, no? Okay, two negative tests or 10 days after symptoms resolution, or and 24 hours with no fever without using fever reducing medications, and COVID-19 symptoms are improving. Okay. What about those with exposure? Okay, so meaning the contacts. Okay, so can a person exposed to a COVID-19 case can be vaccinated? Yes. No, again, there are no known medical contraindications to vaccinating persons who have COVID-19 exposure. If a person exposed to a COVID-19 patient is not in a health facility, then you should first complete the 14 days of isolation before the patient goes to your clinic, okay, for vaccination. So this is an interim guidelines for immunization services during the COVID-19 pandemic. Okay, so this interim guideline is intended to assist us, the healthcare personnel, healthcare providers, in a variety of clinical and alternative settings for the safe administration of vaccines, okay, during the COVID-19 pandemic. So the following slides will tell us, or will show you rather, um, what are the cases wherein we can vaccinate patients in the different settings. Okay, for example, in the outpatient care setting, for no known exposure to a confirmed COVID-19 patients, and we can vaccinate in our clinics. Okay, for those with COVID-19 the past 14 days, close contact rather, or those patients who are asymptomatic, then they can be vaccinated within the 14 days of exposure, because we have this is the time that we have the opportunity not to vaccinate patients. However, patients should not seek consultation outpatient, solely for vaccination purposes until isolation period ends, okay, and symptoms have been resolved. For patients who will go to the ER and wants to be vaccinated, so for those with no known exposure, then we can vaccinate the patient at the ER. Same with the other types of patients with COVID or non-COVID exposure, then you can vaccinate during the quarantine period, to just to make sure that the patient receives the scheduled vaccine dose. Okay? And For patients with who are asymptomatic or pre-symptomatic, again, they can be vaccinated during isolation, okay, within the 10 days of positive, from the time that there was a positive test results. But again, to be sure, no, we just advise our patients to defer vaccination until once they are improved, okay, or once isolation, okay, has ended. Okay. So for inpatient, we can vaccinate our patient at during the time of discharge, meaning while at the hospital. Again, it depends also whether the course of the meaning the symptoms of the patient's resolved. No, there are no guidelines at the present time with regards to recommending the exact time vaccines will be administered in a post-COVID patient. Okay, so most of the guidelines tells us that we can vaccinate as long as the patient is already symptomatic or asymptomatic, na symptom-free. Okay. And settings include another one is the congregate healthcare settings. Okay, just you can just go read through, no? And of course, those are in the correctional or detention facilities. Okay, so we can also vaccinate. Okay, and however, those with close contact, preferably we defer, okay, or postpone vaccination until quarantine has ended. And for those patients who are in the shelters or homeless, okay, again with no known exposure, vaccinate and defer vaccination with contact. Okay, so again, just to be safe, okay, so when we administer vaccines, at least we are protected. We should be protected, of course. And again, I think it's better that we recommend that we defer, no, um, vaccination, especially for those with close contacts and with or with exposure. Okay. So how do we improve vaccination coverage? So this is important because, as I mentioned in my previous slides, okay, so there is a low coverage of the common vaccine preventable diseases, no, especially in the Philippines. So we need to assess, okay, the need of our patient, okay, and assess also what are the vaccines that the patient has received, and if the patient is, for example, still no vaccine free, meaning there's no vaccine given to the patient before the consultation, okay, or this is a catch-up vaccination or a follow-up vaccination, then if the vaccine is available in your clinic, then you administer, no, to avoid, no, skipping the dose, no, during the time of your clinic visit. If, for example, there's no available vaccine in your clinic, then might as well refer your patient, no, for vaccination. Then, of course, you need to document uh, the administration and, of course, the type of vaccines that the patient received during the time that the patient consulted in your clinic. So this is a model, okay, wherein it is very effective in increasing, no, the vaccination rates among our patients. Okay, so basically this is just the same as the one that I previously presented, the assess, the administer, and the document. Okay, so we need to think of certain factors, okay, or ask our patients what are the factors that affects or the reasons why the patient does not want to be vaccinated. So this includes your safety concerns or perceived risk, or are there any issues, okay, concerning misinformation. So it is our role as their doctors or as their physicians to um, discuss to them, okay, so the effectiveness of vaccines. So we tend to motivate them, and we try to check, no, if the patient is ready and willing to be vaccinated. Okay, and of course, you also need to discuss, okay, some practical issues, no, like the cost, okay, of the vaccines. And when the patient's already ready and able, then if the vaccine is available in your clinic, then you administer. If not, please do refer your patients to doctors who have vaccines, in their clinics. So in summary, again, no, immunization is a essential health service that protects susceptible individuals from vaccine preventable diseases. And it is very important that we provide timely immunizations to be able to make our patients remain protected and prevent, no, the likelihood of a vaccine preventable outbreak. And when we prevent a vaccine preventable outbreak, this not only saves lives, but also requires fewer resources, okay, than responding to the outbreak. Okay? Therefore, it reduces the burden to our health system already strained by the, especially at this time, like the COVID-19 pandemic. And of course, we should be aware of the barriers, okay, to vaccination, like lack of information, issues on vaccine hesitancy, and accessibility, which all can interfere with immunization rates. And based on the guidelines, okay, so PCV13 vaccination is no longer routinely recommended for adults above 65, and shared clinical decision making is recommended, okay, especially with the use of your PCV13 in age, 65 years old patients. So if the decision to administer 13 is made, then it should be given or administered before PCV 23. And your PCV 13 is recommended in series with your PCV 23 for adults above 19 but with immunocompromising conditions, as previously mentioned, or those with CSF leaks or those with cochlear implants. And for above 65, only a single dose of your PCV 23 is recommended. So aside from vaccination, especially at the time of pandemic, so these are very cheap, no, recommendation or cheap treatment, no, meaning hand washing, cough etiquette, covering the mouth, okay, exercise and eating healthy, no, because vaccines, okay, reduces the risk, especially for influenza, around 60%, no, and when you administer your pneumococcal vaccine, it reduces the risk of having in the invasive pneumococcal disease by 70%. And of course, another important thing that you need to remember is that you should always stay happy and always smile, okay, and live a healthy lifestyle. Okay, so with that, thank you very much.
Thank you very much, Dr. Giang, for that very timely update about the flu and pneumonia vaccination.
I agree, Doc Tina. Vaccination really plays a very important role in safeguarding our health, especially nowadays. And we should always remember to learn to protect and boost our immune system as much as possible to prevent the complications of these infectious yet preventable communicable diseases.
Yes, and in the interest of time, we will forgo the live Q&A. We have two privately sent questions and we will be posting it in the chat box so that Dr. Giang can answer it. And we would like to present the certificate of appreciation to Dr. Giang for having lectured in the 17th PEFRI postgraduate course signed by the organizing committee. Thank you, Dr. Jude.
Thank you.
Our last speaker for the day graduated from UST and took up his residency and fellowship training at Capital Medical Center and UST Hospital, respectively. He went to the University of California, San Diego, where he completed his interventional pulmonology training, earning him his title of Master Bronchoscopist. He is the immediate past head of the Interventional Pulmonology Unit of the Center for Respiratory Medicine at UST Hospital.
He is the immediate past chief of the section of pulmonary and critical care medicine of UST and is currently the chief of the section of pulmonary medicine at Capital Medical Center. He is indeed a very good administrator and is currently the newly appointed assistant medical director of UST Hospital. It is my honor to introduce to you the magnanimous and mighty Dr. Julius Caesar de Lupang. We can see your slides now, Dr. Dalupang. Thank you po.
Yeah, good morning. So I will just try to fix these slides. Okay. So can you see the slides? Not yet?
We can see it but it's not in presenter view po, Doctor.
Okay, sige po. So there.
There.
Okay.
Perfect, Doctor.
Okay.
Thank you
Good
po.
morning po. Good morning. Okay. So well, first of all, I would like to ask apologies to Dr. Tina for trying to deviate from a little from the topic that was assigned to me. Okay. Well, because I really think that talking about pulmonary procedures at this time would be uh, difficult technically. Okay, so I tried to deviate a little for that from the title that was given to me, and just to concentrate on some lessons that we got from this pandemic. And so and hopefully at the end of this lecture, no, okay, I can still arrive at the gist of this lecture, which is actually how do we actually resume what we want to do, and that is pulmonary procedures. Now, let me start with a lesson from history. Okay, about 5 years ago, no, archaeologists discovered remains of 100 human bodies in a small house, no, and they stack it up, no, this mga small these bodies, no, and they believe that they were actually stuffed hastily because they have to go, no, or to it's a flight of it's because of fear, no, and anthropologists would tell us that these bodies were actually a victim of a prehistoric pandemic, no? And interestingly, that pandemic is found in Hamin Mangha, which is in northeastern China. Okay. Now let's if you Google the 1918 Spanish flu pandemic that killed 50 million people, no? Historians believe that it came also from China because during the time about 100, no, Chinese laborers were transported, no, to the war zone, no, in France, such that they were actually suspected to have brought the disease with them. Okay, and then if we go again to our history, okay, now the Asian flu, no, came also from China, no, it spread to Singapore, and then it went to Hong Kong. And if you look at the next picture, the Hong Kong flu were of Chinese origin. Now, don't get me wrong. I'm not saying that actually that even pandemics now are made in China. No? What I'm saying is that Asia will remain to be a hotspot for pandemics. No? And this is because of the technological advancement, because of the rapid urbanization, high population density, and even, of course, the exotic and wildlife diversity that promotes zoonotic diseases, okay, and that is pandemic. Now, let me show you again, no, another slide that what is actually historians believe that pandemic will come, no, far in between. In fact, for the last since 1918, ang pandemics will come, no, matagal, no. In fact, they predicted that every 10 years may pandemic. But what is alarming in this slide is that if you look for the last 11 years, no, nakalimang epidemic and pandemic na tayo. Okay? And the second message of this slide is that if you look at the figures in the Philippines, like for example in H1N1, okay, that pandemic affected 1.4 billion, no, people and caused about 500,000 deaths. Sa Pilipinas, there are only 5,784, no, affected and only 29 deaths. No? If you look at SARS, 8,000, 12 cases lang tayo. Sa MERS-CoV, 1,000 plus, okay, the 2 cases lang tayo. And when you look at Ebola that almost wiped out, no, the humanity in West Africa, you would take note that nothing, walang dumating sa ating Ebola. Okay? What I am saying now is that the Philippines, as far as pandemic is concerned, we don't have any experience. And if that inexperience can be translated into something, I don't know whether we are really prepared. Okay, but anyway, kahit na prepared tayo, even the first world countries like Spain, okay, France, Italy, no, they are supposed to be prepared, but their healthcare systems actually collapsed, no, during this COVID-19 pandemic. Now, the impact of that pandemic, therefore, is so tremendous, no, overwhelming, no. In fact, we have stories already that in the beginning of this pandemic, no, we were rejecting patients, no, because hospitals were declaring that they are already in full capacity, no. Clinics were closed, such that I believe many elderly physicians would already contemplating of retiring at this moment. And what is really difficult is that there seems to be some disruption of services. Madaming non-COVID chronic diseases that we have not actually addressed for the past many months, no? For example, patients who have hypertension, diabetes, no, cardiovascular diseases, patients with stable COPD, patients with asthma, those who have dermatologic problems, those who need rehabilitations, no? Wala. Okay? And then we have, of course, discontinued or there is some disruption of procedures, no? Now, what is very sad is that at the beginning of the pandemic or at the height of the pandemic, no, okay, this is a figure in April wherein out of the almost 6,000 cases of confirmed cases of COVID, about 766 healthcare workers were affected. That's about 13%. The figure would be the same as in other countries, no? And out of these, half of these, more than almost half would be doctors, okay? Another 200 plus are nurses. And then, of course, no, we have 22 fallen heroes who have sacrificed their lives in serving humanity. Okay. Now, if I'm giving you a grim picture of the pandemic at the start, no, the impact actually of that pandemic, no, in the whole system, healthcare system, would be to really bring, no, chaos, panic, and fear. Okay. And in fact, during the time that we were actually contemplating, kailan ba babalik yung normal? Okay. At okay, when do we do the things we love to do? No? Okay. And I was in that contemplating mood actually when at one point in May, I was called to address a patient with a recurrent pleural effusion and mediastinal lymph nodes. No? So this is a problematic patient. Okay. We've been treating for recurrency of the pleural effusion. Walang response with antibiotics, no? Ganun pa rin, okay? And then CT scan showed mediastinal lymph node. So what do we do? Okay. So our team came in, of course, and this is actually a time to be brave, as they say, in times of fear, okay? And you will notice the picture, balot na balot kami. We were mummified, as I said, that even our instruments, no? Nakabalot ng mga instruments ng plastics, no? And if you will remember, halos lahat, no? In the hospitals, no? There are so many plastics, no? Covering everything, okay? Yon, that was the scenario. And then, of course, this procedure made me realize that for us to be brave in times of fear, then we better learn how to sleep with the enemy. And we better learn to adapt and to transform the way we do things. Okay. Now, of course, no, how do we learn to sleep with the enemy? Let's study the enemy. Okay. Alam naman natin to, no? Alam naman natin that the transmission of the SARS-CoV-2 virus would be several pathways, no? So the moment I'm speaking right now, kung ako'y may COVID, no, I'm spewing, no, large droplets, no, or small droplets. These large droplets may be mostly water, but it's infected, and because it's too large, no, it just falls into the ground. Okay, small droplets, on the other hand, no, they are suspended into the air. No, they are travel far. Okay, they are being brought by air currents, and they will travel far. Now, there's no definite delineation as to the size, what is large and small, no? But they said that it's about less than 5 microns, no? Okay. The small droplets are also called droplet nuclei or aerosol. So as I am saying right now, as I am talking, I'm actually spewing large and small droplets. Okay. Now, an aerosol can be generated anywhere, no? And if you will look at this slide, they are actually commonly produced, this aerosol, no? And in fact, an aerosol that may contains this virus, no, may actually be just around in the air, no? So common procedures like intubation, bronchoscopy, or even cardiopulmonary resuscitation, no, they generate certain type of aerosol. If you ambubag a patient, if you do suctioning, then you also generate aerosol by the mechanism of mechanical dispersal of that aerosol. Now, there's no study or this study as far as transmission relationship ng different aerosol generating procedures, no, with infection, no? So they are all speculative, but we know that anything that generates aerosol, no, in this time of pandemic would be a potential source of infection. Okay, so that's the first lesson. Okay, and if you look at the aerosol generating procedures in this slide, no, they are too common, no, bronchoscopy, no, CPR, okay, non-invasive ventilation, then even nebulization, sputum induction. So they actually generate aerosol. Okay, so that means that if we are doing all these procedures, then there must be actually a strategy, no, to control the infection. And what are these strategies? No, there are actually 4 strategies. No, and this is what we learned. No, we learned to transform now the way we perform these aerosol generating procedures. Number 1, of course, would be patient evaluation and risk stratification. So alam na natin yan. Okay? Meaning yung memory natin, it becomes automatic as far as trying to evaluate patients with history or symptoms of COVID. No? Then we alter our environment. Di ba? Okay? We want of course to set negative pressure rooms, no? So in your clinics, I'm sure meron kayong mga exhaust fans diyan to promote air circulation. May mga air purifier kayo, okay? That is one strategy to optimize patient environment. Then as far as procedures are concerned, no, we are guided, no, by the principle of a medically necessary time-sensitive procedures. No? Ito ba'y necessary? Okay. If it is delayed, meron bang mangyayari? Okay. So it means only on the urgency of the procedure wherein we decide kung gagawin ba natin yung procedure. Okay. And of course, the other factor is will there be any alternative procedures, no, for you to do, no, to get a diagnosis, for instance. Okay, so ginagawa naman natin yan even before even COVID, no, we try to weigh the risk and benefit of every procedure, and that's a principle na wag nating kakalimutan, COVID or non-COVID. And of course, what changes really is we have to maximize, no, the healthcare workers protection. Okay, I remember that during the first few months of COVID, no, okay, Dr. Lansona, my boss, no, nagra-rounds kami sa emergency room, wala kaming mask, and I was saying na ironically lahat naka-mask but pulmonologists hindi naka-mask, no, but we learned now, of course we learned our lesson, and now it becomes already a part of our ano to, attire, no? Okay, yung mask na yan. Okay. So, ano yung mask na kailangan natin? Okay, if you have a level 4 procedure, of course, then that picture will tell us, no? Yung ano yung kompleto from the surgical cap, coveralls, scrub suit, no, goggles or facials, and 95 mask, no? Yun yung minimum. For me, the minimum mask would be an N95 when you are doing procedures, especially pulmonary procedures. Okay. Now, if you look at the aerosol generating procedures, no, you can be safe as long as you maintain these 4 strategies. One, as I have said, the risk stratification. You optimize your patient environment. Then you decide whether this is a medically necessary, time-sensitive procedure. Okay, and then maximizing your protection. Photosynthesis and sleep studies, well, they are not really considered as aerosol generating procedures, but then again, if you are doing those procedures, then it's best, of course, that at least one of these strategies will be utilized, no? For example, okay, you have to optimize your patient environment, okay, meron ka pa ring risk stratification, and of course, you still need to protect yourself, kahit na minimum protection like N95. Okay. Now, it is often said that in patients, no, with COVID, no, you don't nebulize, no? Yun yung natuturo, no? Okay, sa umpisa, okay? But you see, no, this is not absolute, no? What about if patients coming in now with severe life-threatening respiratory disease, no? Okay, then hindi ka ba mayroon bang mag-nebulize? Or it's difficult to instruct your patients to use your MDIs at that time when nahirap siyang huminga, okay? Or probably that patient has a poor history of MDI use, no? Okay, so what do we do? Then we alter. We become more resourceful, no, as far as using nebulization during COVID-19, okay? At ito yung ginagawa natin. While we prefer, okay, your MDIs, if there's no choice but you do your nebulizer, then what you can do, of course, that instead of face mask during nebulization, you can use the mouthpiece. And at the end of that mouthpiece, you can actually place an air filter, no? This is readily available, okay? You can buy it anywhere, no? Okay? Now, you can also use your NIV face mask, the tight-fitting mask, and at the end again of that, no, of this gadget would be your air filter, okay? Now, of course, you can do it if you have negative pressure rooms. Well and good, because that will actually lessen, no, the transmission of aerosols, no? Okay. Now, they said, of course, that during this time of necessity, no, necessity becomes the mother of inventions. So this is an nebulizing booth that was improvised, no? This is an improvised negative pressure room, no? So sa loob niyan, if you will see this one, yung may airflow, no? Ang airflow is unidirectional, going out, and those going out of the booth will have to pass through a filter, no? A HEPA filter, no? So yung nilalabas, no, ng air from that booth will be air that's purified, no? Okay. So yon, that's an improvised negative pressure room. Now, during the time of pandemic, nako, okay, we have so much of patients going into respiratory failure, and intubation, no, is the most frequently pulmonary procedure that was done. Okay. Before COVID, we don't have any much protocol. But after COVID, we have transformed ourselves to develop a protocol wherein we actually form a dedicated intubation team. So once na merong COVID, no, that needs to be intubated, this intubating team will only be called in place, and they have a respective roles to do. Okay? For example, yung nurse na yon, okay, kino-compute na niya yung weight ng pasyente, at kino-compute na niya yung mga medications that are given, no? While people are already preparing, no, to dress themselves during intubation, no? So, because well defined, no, ang role ng every, no, part of the team, we actually limit personnel. And that less personnel, less exposure, less infection. Okay? And of course, yung gagawin would be the most experienced anesthesiologist. No? Sa yung pinakamagaling, yung designated. So even before that, dapat nagpa-practice sila. And to lessen the exposure, then video laryngoscope is preferred. Okay, meron ng mga cheap video laryngoscope that we were able to buy in Lazada or Shopee, and that was used, no, during intubation. Then 5-minute pre-oxygenation with 100% oxygen, and then rapid sequence intubation is the strategy, meaning we knock out this patient, then do rapid intubation. Okay. While we are bagging this patient, no, you will notice that in this ambu bag, no, meron na namang naka-attach na filter, no? And that again, no, will lessen or will alter the environment in this setting. Now, again, these are some inventions because out of necessity. Yung aerosol boxes, di ba? Nagkalat yan, no? Pagkatapos, meron ngayon yung mga negative pressure tents, no? This tent, no, will be, for example, attached to a suction machine, and that it serves as a negative pressure tent. Okay. Now, we question, of course, we were doing all these things, but we are throwing away any evidence, no, based literature already about this, no? Okay. And so I tried to look for some evidences. Ito ba effective? No? Okay. And they found out that, well, we don't know. Okay. One is, it probably adds complexity of the airway procedure. Mahirap mag-intubate, no? With your 2 hands, no, inserting in the hole in that the aerosol box, no. Then sometimes, no, kahit na you are limiting, no, the dispersal of aerosol during that time, no, we don't have evidence that it will add, no, protection to healthcare providers. In fact, kapag tinanggal yung kwan na yun, it will just disperse, they said, no? And then the other, of course, is how do we clean it, no? There's no standard cleaning procedures as far as this aerosol box is concerned. In fact, even nga yung mga acrylic barriers in our clinic, well, it's useless if you don't clean it. Okay. Now, of course, once na intubate, it should be standard that you will be using your closed tube suction system, no? This is a picture of a closed tube suction system, and if you don't have that in your facilities, then you better get one, no? These are cheap cheap materials, no? But their advantage is very significant. Okay. Once intubated, we don't nebulize. Okay, we devise ways wherein we can deliver our MDIs, no? Okay, so may mga iba-ibang ways, no, to deliver your bronchodilators, no, using your MDIs, no, and it is shown in this picture. Okay, Of course, meron ding mga gadgets that can actually deliver nebulization. This is one gadget, no, that can actually be attached, no, in the inspiratory limb of your ventilator. Now, okay. Now, during the time of pandemic, okay, definitely, okay, habang bumabagsak na, okay, how do we actually address patients now, no, who are non-COVID, no? Although mahirap sabihin whether COVID siya or non-COVID, but the question is, how do we resume the things that we are doing pre-COVID? And this is a framework, no, for the prioritization of elective medical services. So when we say medical services, pwedeng non-invasive, pwedeng invasive. Okay? Now, one is the tier 1. No? The tier 1 are those don't have any acute symptoms. No? So, kumbaga sa 1, kailangan lang nila ng mga follow-up. Okay. Group 2 patients or the tier 2 patients are those who have symptoms, no, but not really emergency, no, and these are patients na
Dr. Don?
or group 3 patients have emergent symptoms, no. Okay, if you look at this format, no, okay, and you factor in, of course, your resources. Okay, will you be able to address, of course, the influx of these non-COVID and COVID patients? Number 2, what would be the preference of your patients? Siyempre, ang major deterrent for patients coming into the hospital would be takot sila. Okay, and the third would be the prevalence. Okay, so if the prevalence of the disease, for example, is high, then those who don't have much acute problems, no, they are better served with telemedicine. Those patients with mild symptoms, no, okay, then we offer them, no, an option, ito by telehealth or can they be seen, no, in the clinic, no? But when they are seen in the clinic, of course, they are being screened already for COVID-19. And it seems that in patients, no, who have emergency symptoms or who have acute problems, then it seems that regardless of the prevalence of the disease, then we will have to address these patients. Okay. Now, so how do we resume performing elective procedures? How do we resume doing, no, our clinic work, no? If we call that your elective procedures, no? Number 1, you'll have to take note of the downward trajectory of confirmed cases over a 14-day period. So kung bumababa, no, pwede na. No, okay. Now, sometimes mahirap, you know, with the reliability of our data that we're getting, sometimes mahirap when you can see already some downward trajectory. Okay, but the one clue there is that kung bumababa ng admissions ng hospital, then probably there's already a downward trajectory. Now, second, of course, that you should be able to address, no, okay, all patients. So kung inopen ng facilities nyo, then you should be able, you should have equipment or the capability or the workforce to address the surge of patients, no? And then the third, of course, would be the availability of testing program in place, no, for all healthcare workers. Okay, now, so based on this, therefore, okay, based on the prevalence that I was saying, okay, now, if you have already an absence of cases in the last 2 weeks or downward trajectory, no, whatever procedure na pwede na, no, kaya simpleng procedure yan, kaya simpleng dermatological procedure, pwede na. Okay? Even if it's elective, not delayable, or elective, pwede na. But once that there is still an exponential increase of new cases, then we will just be addressing the urgent cases that may need immediate procedures. Okay. Now, of course, when you open your clinic, when you open your hospitals, when you decide to do procedures, whether elective or emergency, then you have to keep in mind the strategies that I was mentioning about how to keep this procedure safe. That is an adequate patient evaluation and risk stratification, modification of your environment, and then the decision whether that procedure is really necessary. And of course, the last would be your own protection. Now, how do we risk stratify? Well, you're very familiar with this. You are master of this risk stratification, okay? But the recommendation is that if you are triaging a patient, if you are screening your patient to come in, that they should be, the effectivity of that screening procedure should be 72 hours of the scheduled appointment. Hindi pwedeng na telemedicine mo siya ngayon pagkatapos pupunta sa clinic mo after 2 weeks. No, that's too far. So we don't know kung ano nangyari between now and 2 weeks after. Okay? Now, ideally, of course, that when you are doing procedures, especially aerosol generating procedures, then your swab test will be ideally done within 48 hours of the scheduled appointment. And in UST, the guideline, the IPCC guideline, the swab test is effective for 14 days, has an effectivity of 14 days. We require, of course, in UST to have chest X-ray and CBC of 1 year interval.
Sorry for the technical difficulties. We are awaiting Dr. Don Dalupang to resume back his lecture.
Okay. Can you see me again?
Yes, doctor, we can see you po again.
Okay. Anyway, so that broke my momentum. Anyway, so as far as pulmonary function test, as I have said, is that how important is it? No, okay, and there are so many pulmonary function tests that are actually classified as higher aerosol generation and less aerosol generation. Okay, kung pwede naman ng 6-minute walk test, no? Bakit hindi, no? Bakit pa kailangan yung mga long volume studies, no? Okay, so pwede na 'yon. Okay? Now, the requirement, of course, that if you have pulmonary function test, then you do your SARS-CoV swab test within 7 to 2 hours of the test. Okay. Now, so it's really my internet is really unstable, but I'm trying to move this slide. But anyway, okay, as far as bronchoscopy is concerned, now, okay, let me just go out for a while, I think.
Doc, any last words na lang po in the interest of time? Opo, doctor.
Yes. Anyway, the thing that we are uh, my lesson actually here is that when you are doing procedures, no, okay, there are only three lessons that we get from all this on my discussion. No, number one is that um, there's no emergency in pandemic. No, we'd always heard that before. No, meaning if you are doing any procedures, no, okay, you always have to prepare yourself. Meaning you have to take time, no, as far as equipping yourself with the right personal protective equipment. The second lesson from this pandemic is that, okay, the healthcare worker is the most valuable asset we have right now. You are a multiplier, no? If you fall sick, okay, you may affect your families. You are less, no, workforce, no, in the frontliner. And if you die, if you have fallen, then we have less, no, worker to address to save, no, lives of people. Okay. And the third lesson, and that is actually the most important lesson that I would like to do, is that in this time of crisis and change, no, the only resource we have is our resourcefulness and our resilience. Okay. And with that lessons, I think we are prepared for the next pandemic. Thank you. So
Thank you very much, Dr. Dalupang, for that very practical lecture. We should always remember the three lessons that Doctor taught us. No, there's no emergency. In the during the pandemic, we should safeguard our frontliners' health and well-being, and of course, we should be resourceful and resilient.
Agree, Dr. Tina. So, in behalf of Dr. Dalupang's lecture, we would like to present the certificate of appreciation to Dr. Dalupang for having lectured in the 17th postgraduate course.
So we've just finished our four lectures for the third day. Please do not forget to join us in our industry-sponsored symposium right after this session by AstraZeneca and at 5 p.m. by Abbott. The link is available at our website and is also posted here in the chat box and also in our Viber chat group. Please don't forget to fill up the feedback form for today's session as well, and see you on the other side. Good morning.